Hello, ladies and gentlemen. We are still waiting for our participants to come.
We are going to start in 3 or 4 minutes. Ladies and gentlemen, we are very glad to welcome you to the second day of our conference. We are certain that this day will be equally interesting as the previous one. We will present you the wonderful lectures, experiences from the Erasmus Plus program internships, and amazing workshops. The transmission from yesterday can be found on YouTube. So if any one of you missed it, we encourage you to watch this video.
We would like to remind you that the aim of our conference was to join the students of different countries who would like to develop themselves abroad. And we succeeded. Among 420 registered participants, there are guests not only from Poland, but also from Italy, Bulgaria, Slovakia, United States, Sweden, or Albania. Welcome once again to our first edition of International Medical Erasmus Conference 2021.
We would like to briefly present you today's program. In a moment, at 9:15 a.m., the first lecture session will be opened and will last 1 hour till 10:15. You will have an opportunity to attend thrilling lectures in the fields of psychiatry, endocrinology, and surgery. Then we will move on to the presentation panel of students who participated in internships with Erasmus Plus program in various parts of Europe, in Czech Republic, Austria, Denmark, Italy, and France. All of these students will be here with us today, so we'll be able to ask them questions about their internships.
At 11:15, We will invite you to a brief 15-minute coffee break, during which we will again present you our partner universities. After the break, the second lecture session will begin, in which you will hear lectures of our guests from universities in Poland, Germany, Slovenia, and Spain. Then we will move to the discussion panel, to which we invited two medical doctors working abroad, Julia Tryzna from Denmark and Anna Gumulska from Germany. Their experiences will surely be relevant for everyone who would want to begin their work abroad in the future. After the panel, we will invite you to a lunch break, which will be followed with an interactive quiz on the platform kahoot.it. The questions will concern the lectures presented today and the Erasmus program itself. Therefore, we encourage you to listen carefully.
Same as yesterday, the winners will receive gift cards for Amazon, MedHoodie, and Empik. Quiz is the last part of our today's meeting, after which we will move on to the closing ceremony and finish the transmission of an event at YouTube. However, that doesn't mean that's the end of our conference. Participants who registered for the workshops will be invited to the rooms where you will take part in the chosen events.
During the conference, you may ask questions to the lecturers using the commentary section at YouTube. They will be then read to our speakers, depending on the availability of the time left.
So, without further ado, we would like to invite Professor Jan Pecenak of Comenius University of Bratislava, who will present a lecture, How to Untie a Gordian Knot Called Schizophrenia. Now, Professor, you may share your presentation using the Share Screen button.
Okay, hello everybody. Thank you very much for inviting me to this important conference. I would like to share my lecture or slides. Okay, I hope that you are seeing my slide.
Yes, we are seeing your presentation right now.
Okay, so...
But we see it as a PowerPoint file, not as a presentation itself.
Okay, so I will try to...
Perhaps you should try sharing your screen, not the PowerPoint presentation itself, but first the screen. And now you can run the presentation.
Now we can see your PowerPoint, Professor, and you need to, yes.
It's okay. It's okay. Yes.
Perfect. Yes.
So I choose quite provocative title of my presentation, How to Untie a Gordian Knot Called Schizophrenia, because I must say that maybe future will show us how to untie this knot. It is not now, I would say. We must start with some history, and in psychiatry, we must be oriented in historical terms and concepts of schizophrenia. So I would start with Emil Kraepelin, who was first person able in, I would say, official classification to describe schizophrenia, but he called it dementia praecox. Why? Because he stressed the long-term deteriorating course of schizophrenia.
Excuse me, Professor, we have to ask you to click on the nastawienie zobrazenia.
Yeah.
On the upper part, to the left, there is, yeah, you can click on it. And okay. Now, yeah, the first one, yes, this is what, yeah, exactly. Now it's perfect. Thank you very much. Sorry for the interruption.
So once more, that Emil Kraepelin described something, some condition, and he called it dementia praecox because there was a group of patients with long-term deteriorating course of this mental disease. Eugen Bleuler later, he didn't accept this term dementia praecox. Eugen Bleuler in Switzerland was much more involved in psychological dimension of schizophrenia or of this disease. He was also in contact with Sigmund Freud, and he renamed this clinical condition as groups of schizophrenia, and he identified four principal or fundamental symptoms, and it was associations or disturbance of associations, affect, autism, and ambivalence. The prevalence of schizophrenia is about 1%. The question is that why schizophrenia is still pertaining in the population, because we know that people with schizophrenia has less children, and they often have no partnership and so on. And it is very nice explanation from very known psychiatrist Timothy Crow from Great Britain, and he explained it that schizophrenia is the price that Homo sapiens pays for language, and that maybe something in genetics or in human genome occurred, and when Homo sapiens start to use language, also schizophrenia emerged. Why schizophrenia is so important? It is one reason that schizophrenia starts usually in early adulthood, and you can see here the peak of incidence of schizophrenia is at about age of 25 years, and it is a chronic disorder, usually lasting whole life. So it is a big burden for person and for society. Here is at this picture, there are some stages of schizophrenia, and you can see here the so-called premorbid stage, prodromal stage. In this prodromal stage, there are some changes of behavior, of interest. The parents can say that my boy or my daughter was changed and he or she is different in comparison with previous life. After that, we have so-called progressive change, and symptoms of schizophrenia are emerging, like hallucinations and delusions. But what is important that after that, in many patients with schizophrenia, there is a residual change, and in this phase, there is a change on functionality of patient, of emotional life of this patient. So we have some treatment possibilities, but usually this residual change occurs in patients. Here is the same slide or same principle as in previous slide, but it was published by Thomas Insel, previous head of National Institute of Mental Health. And it is, here is much more stressed the neurobiological finding in schizophrenia. So we can see that somewhere here, there could be a problem with proliferation with neuron, with migration of neurons, with arborization of neurons, and it is during the prodromal stage of premorbid or prodromal stage of schizophrenia. Somewhere here in the late adolescence and early adulthood, something is going wrong. And maybe because of stress, maybe because of using of drugs, but somewhere here in this period of life, the symptoms of schizophrenia are emerging, and here are residual symptoms. What about etiology of schizophrenia? It is explained that we can describe about 80% of etiology of schizophrenia to be caused by genetic factors. But what is the problem? That also, even in monozygotic twins, there is only about 50% of concordance of schizophrenia between these twins. And the most common question is that if I have a partner with schizophrenia, what is the risk for our children that they will have schizophrenia? And it is about 13%. So it is 13 times more than prevalence in common population. Okay, if it has a genetic basis, what are genes for schizophrenia? We have no clear answer now. I would like to show you the very, very important work published in Nature, and you can see how many case control groups, how many patients was involved in this genome-wide association study. So we can see here in the right some known pathophysiological factors which are involved, like gene for dopamine receptor, genes for glutamate, calcium channels, or neuroplasticity. But what is important that this one change of genome is connected, most important, is connected with major histocompatibility complex. So it is like that identity for schizophrenia is given by general genes. I would say that they are giving the biological identity of the person. So we have a person with schizophrenia, and we know several symptoms or several syndromes which are typical for schizophrenia. Firstly, there are positive symptoms like delusions, hallucinations, and disorganization of thinking, of behavior. But what is important, that are also negative symptoms like affective flattening, alogia, abolition. And these negative symptoms are maybe more important for functioning of person with schizophrenia, more important than these positive symptoms. In several years, there was a stress that there are cognitive symptoms which are the basis for schizophrenia, like attention, memory, or working memory, and there are also mood symptoms. Mood symptoms like dysphoria, which can result in suicidality. It is very important for schizophrenia. Maybe 20% of people with schizophrenia commit suicide. These symptoms have impact of overall functioning, and it is functioning in social, occupational work, or personal dimensions. I must say that I was surprised that even in very, I would say, rich countries, 80% of people with schizophrenia are not working. It is similar as in Slovakia. The question is that we have these dimensions of symptoms and dimensions of disturbance of functioning, and how these symptoms are corrected. Are more important positive symptoms or negative symptoms? What is association between cognitive symptoms and functioning, working, or with negative symptoms and cognitive symptoms? It is one way or one topic how to catch this very complex problem of schizophrenia. I will show you that we are also trying to find such answers. And here is a chart from our publication. When we analyzed the theory of mind is a theory, or it is a psychological principle. If some person is able to understand other person, the intentions and also emotional status of other person. Here we have part of cognitive functioning, which are called executive functions, and social activities and social functioning. So I will not explain the results, but it is an approach how to catch the complexity of the symptoms of schizophrenia. I would like to show you very interesting, and I would say that now it is the line, it is approach how to catch this, and this is a symptom network. And we can see here, for example, a complex of hallucinations and delusions, typical psychotic feature of schizophrenia. Yes, and they are together, and they are connected to other symptoms or symptoms dimension. Maybe this is the way how we can identify better the groups of the symptoms and try to change it. Now I would like to mention the one of the theory of schizophrenia. It is dopamine theory. It is based on the mechanism of effect of antipsychotics. Antipsychotics, previously called neuroleptics. The main mechanism of effect is blockade of D2 receptors. I would like to mention the Professor Arvid Carlsson, who got Nobel Prize in 2000, and he created this dopamine theory of schizophrenia. So antipsychotics are working on the D2 receptors, dopamine 2 receptors are blocking in different way these dopamine receptors, but it is the principle of mechanism of effect. We know several dopaminergic pathways in the brain, and we are clinically working with this, or thinking in clinic about these 4 pathways, and it is mesocortical, mesolimbic, nigrostriatal, tuberoinfundibular pathway, and they are connected to the healing effect of antipsychotics, but also with adverse effects. Yes, but we know affinity of antipsychotics and other drugs, but what is behind these receptors? We were trying to partially answer this question, but our work in cooperation with my colleagues from Slovak Academy of Sciences, and it was an animal model, and animals, rats, were getting 4 antipsychotics, olanzapine, amisulpride, aripiprazole, and quetiapine. And we also studied the precondition of stressing this animal or not stressing this animal before getting these antipsychotics. And so it is the look not on receptor affinity, but on the in changes which are going in the brain of these animals in a special nuclei of the brain. So there are some surprising results that amisulpride, you can see that not many changes are here in dorsolateral striatum, which is part of basal ganglia, but there are changes in nucleus accumbens, which is part of limbic system. I would say that we would not expect such difference. So it is one of the approach how to look behind receptor, behind mechanism of effect of antipsychotics, to have a look at the changes at the target of these antipsychotics, at the brain cells and brain connections. So the question is, what is the future in studying schizophrenia? We will have better answer for schizophrenia, for symptomatology, for treatment. And I suppose that it is emerging topic of big data, and big data in psychiatry, and you can see here the journal with this title, Big Data in Psychiatry Neurology. The book were published, and I think that big data could explain this complexity of symptoms and complexity of etiological factor. I would like also mention the Sir Michael Rutter. He died in September this year, and he is one of the greatest psychiatrists in history of modern psychiatry. He was a person who identified that child autism is not a form of early schizophrenia, but developmental disorder. But I think that I know that autism and schizophrenia has many overlapping symptoms. And I think that the research of child autism could explain some very important questions about schizophrenia. So it is one way of looking for it. And the other way is so-called experience sampling method. We are starting to do it at the clinic. So patient is not inviting for control. You are not sitting with him in the laboratory or at the clinic, but he will get notification of a smartphone, and there are several questions. Patient is answering this question about stress, for example, if he is in society or not with somebody. And so it is a method that could help. So it is the end of my presentation lecture. Thank you very much for your attention. And now you can see here the very nice look at I am speaking from. Thank you.
Thank you very much, Professor, for this wonderful lecture. It was very nice to hear it. And we have a question, actually. It was mentioned during the lecture that DRD2 gene might be involved in pathophysiology of schizophrenia. This gene encodes protein for dopamine receptor and is often mentioned as to be involved in the development of addiction due to being part of dopaminergic pathways. And therefore we have a question: are the patients with schizophrenia more at risk of developing addictions?
Okay, so I would say that it is one topical specialization in psychiatry, so-called double diagnosis of schizophrenia and addiction. And I think that it is very much given also culturally, because in Slovakia, maybe in Poland, for example, cocaine is a very expensive drug. So we don't see many people who are coming to psychiatry with a problem of cocaine. We have pervitin here, pervitin, and pervitin can cause paranoid psychosis, toxic paranoid psychosis. I must say that the problem of schizophrenia is much more important for us in combination with marijuana and tetrahydrocannabinol, because it can complicate the healing process and can pertaining some symptoms. But excuse me, if I can answer it more broadly, it is not only dependence, but it is also in ADHD, for example, in attention deficit hyperactivity disorder, when also drug stimulants are working through noradrenaline and dopamine. This is a problem in psychiatry, that it is so much complex, these reasons, this etiology, and after I like to say that our brain is more complicated than our mind. The different processes in our brain are finishing in one answer if in our mind, for example, in depression or in anxiety. But behind depression and anxiety, so many pathophysiological processes can be running in the brain that we are still, like I would say, blind person in the forest, yes, with it. So the complexity is very big.
Thank you very much for this very descriptive answer, and once again for this wonderful lecture. And now we would like to introduce you the lecture of Professor Zalika Klemens-Ketish, I hope I pronounced it correctly, of University of Maribor and Ljubljana, who will tell us more about use of simulation in primary care education. Thank you for joining us, Professor, and you may start your lecture now.
Okay, hello, good morning to everyone. Let me just share my screen. Okay. Yes, as presented, I'm Zalika Klemens-Ketish.
Now we cannot see your presentation, Professor.
Okay. Yeah. Can you see now?
Yes, actually we can see your, I guess your program, but not the whole presentation itself.
I will try again.
Maybe you should try to share your whole screen, not selecting the PowerPoint itself.
Yes, exactly.
Yes, now we can see your presentation.
Thank you very much.
Thank you, sorry. So I'm Zalika Klemens-Ketish. I come from Slovenia. I am a family physician and also the Associated Professor of Family Medicine at the University of Maribor and University of Ljubljana. As a family physician, I'm still working with patients in Ljubljana Community Healthcare Center. This is the largest community healthcare center in Slovenia, and we cover approximately 1/4 of the whole population in Slovenia, and we have around 1,600 employees. And the need for educating the healthcare teams that are working within our community healthcare center led us to establishing the simulation center, which is one of the most advanced in Europe. And we use advanced simulation to primary care education. And I would like to present to you today one of the methods that we use. So I guess this is more or less familiar. Primary care is the first entry point to healthcare system. And we are working at primary care, we face a wide range of health conditions, symptoms, signs that patients come with them. Patients come to us. Also, early stages of diseases are seen. So there is quite a high level of uncertainty that we have to deal when we manage patients. Also, a lot of patients come with unselected symptoms. So the family physician and nurses and others that are working should have very broad knowledge and also a lot of skills to manage this wide range of health conditions. Also, we could face some life-threatening situations. For example, anaphylactic shock or cardiac arrest or heart attack or something like this. This doesn't happen very often, but when it does, it is really very, very stressful, and there is a need for fast management of such situations, and we need to have up-to-date knowledge to manage such situations. This can be difficult if we are not dealing with such situations every day. Emergencies in primary care namely occur rarely, but they require prompt response and also a well-coordinated team. Because if you imagine, if, for example, a patient collapses in the waiting room in the primary care, different members of team can resolve this situation, and this team needs to be very well coordinated. We need to have up-to-date knowledge and skills, but also up-to-date equipment. because we use the equipment for emergency situations that we don't use every day. It can happen, for example, once it happened that we wanted to use the defibrillator, but it wasn't charged with batteries. And this is also a problem, not only the lack of knowledge and skills. Previous studies in this field show that there is a lack of practical skills among the teams that are working in primary care. There are also difficulties in coordinating a team, which can result in unsafe or less safe management of such patients. And there is also problems in coping with stress and unexpected events, because such emergency situations are rare, but they are very intensive. And if primary care workers are not used or trained to manage such situations, they can, a lot of stress can evolve during the management of such situation and also after it, and this can affect the safety and also the level of managing such situations. So as I explained in my introduction, we in our simulation center developed three-level education for primary healthcare teams mainly on managing urgent or life-threatening situations. There is at the beginning, when our teams enter our education, they come to our center, and we are doing the education, the level 1 calling classroom high reality simulations. The content are mainly the managing of cardiac arrest, childbirth, and also trauma. And here they learn in the classroom about how to manage these situations. Then we have level 2. These are in situ simulations. We call them in situ simulation because we bring the simulation into their workplace, so into their practice. And they have to manage this clinical case scenario that we are performing through simulations. And then there is level 3, simulations with augmented reality. We developed our own module with augmented reality. I will show you later for managing anaphylactic shock. How first I will describe this first level of education, classroom education with high reality simulation. First, usually this education lasts for 1 day. First, we introduce some theoretical facts on resuscitation and cardiac arrest and CPR and so on. Then our participants practice the hand skills such as intubation or performing cardiac massage and applying drugs and so on. Then we use advanced simulation. Here we use very high reality or simulators, and then there is a mandatory step debriefing where we used this structured tool for debriefing. It is called talk tool, where we discuss with the participants what was good, what could be better, so they learn through this active process of debriefing. Of course, the goal of our teaching is patient safety. These two photographs present low fidelity or simulator with low realism. You can see this is the simulator of a child, but it's not very close to real child. But here is also the simulator, but it is a high fidelity simulator. So you can see it's sometimes difficult to tell if this is a real child or a simulator. And you can imagine that when we use this kind of simulators for education, we can mimic the real situation very, very accurately. And this also helps our participants to deal with stress and unexpected situations like emergency situations are. Then we go to the second level. These are in situ simulations. As I explained, they are performed in a workplace. So our team of educators go to the practice of one primary healthcare team, and they bring the simulator. This is another one of our simulators. It is a middle-aged man. This is also the simulator. It is not the real person. So then we, in the workplace of our teams, we perform the simulation. For example, this patient collapses in the waiting room, and the team needs to use its own medical equipment and also needs to be well coordinated, and then they need to resolve this simulation of emergency situation. By this, we accurately imitate the real situation, and we can test the knowledge and the skills of the participants, but also we can test if they are able to resolve these emergency situations within their workplace with their own equipment. And through this process, we can identify also some safety problems that they might have, which could impact the management of the real emergency situation, and we can improve or resolve this conditions, so that in the future, when they will face with the real patient, they will perform the process of managing will be better and more safe. The third level is augmented reality. Augmented reality is a fusion of a projected computer-generated images in the real-life clinical environment. This is in contrast to the virtual reality. In virtual reality, all you see through these virtual glasses is not real, but in augmented reality, you can, for example, use your own practice, but through a virtual augmented reality, you can project the image of the patient. This augmented reality enables recognition and managing of rare medical situation. We decided in our simulation center that we will develop a module, a clinical case scenario with the patient with anaphylactic shock after drug administration. So this is a very rare situation. Maybe in my 20 years of practice, I faced such kind of patients twice. But when this patient comes, you need to know how to resolve it and how to basically save the patient's life. So this picture presents what you see through the virtual glasses. This is the practice, the real practice, and this is, if you can see, the virtual patient. And this patient, the clinical case scenario is like that the patient, the virtual patient receives the drug, and then she develops this anaphylactic shock. And a trainee, a doctor, needs to know what to do in order to resolve this clinical situation. If the doctor doesn't perform all the procedures correctly, then the patient gets worse and also dies. So this is also can be quite a stressful experience for the learners. This picture I already showed. I placed the augmented reality here between hand skills and advanced simulation because through augmented reality, you can practice also how to manage the life-threatening situations, and then you can show what you learned in advanced simulation. There are currently not a lot of studies that dealt with the effectiveness and the use of augmented reality in teaching various medical situations or medical emergencies. So currently in our healthcare center, we are performing a randomized control trial to prove or to see if the augmented reality is effective when included in the already routine learning for medical teams. So for conclusion, simulations offer us a safe educational environment where we can safely learn about also very difficult or demanding medical situations that we can face in practice. This is a dynamic education. It fosters teamwork because usually the team needs to resolve the patient in the simulation. It is very important that we enable teaching of management of rare situations so that we are experienced and skilled when the patient really comes to our practice with such a condition. It helps coping with stress, but there are currently very few studies on this topic, so further research is needed to prove what is really effective and how it needs to be done. Thank you very much.
Thank you very much, Professor, for this important insight on this topic. And while we as future doctors know that this is crucial for patients' life, and learning this by simulation is certainly much more effective. So thank you very much once again. And now, how aberrant adrenal transdifferentiation causes the development of endocrine hypertension is a title of the next lecture, which will be given by Professor Holger Willenberg of University of Rostock. Welcome, Professor, and you may begin now.
Thank you very much for your kind invitation. And as you said, I want to, let's say, show you insights into the riddle why maybe one child of yours will develop differently than your other child. And I called it how aberrant adrenal transdifferentiation causes endocrine hypertension. So, now I can go forward here in my presentation. The adrenal gland is controlled or is under the control of the hypothalamo-pituitary adrenal axis, as the endocrinologist says, and the negative feedback is exerted by a suppression of the immune system, which is otherwise a stimulus of this axis, or by the suppression or the upregulation of glucose output, and so on and so forth, and of course by cortisol itself. Nephrologists used to say that the adrenal function is under the control of the renin-angiotensin-aldosterone system, and aldosterone exerts its negative feedback via reclamation of sodium, which then causes thirst and reabsorption of water and hypertension. And of course, there are various similarities between the systems, and there are also interactions. And nevertheless, these two inputs of signals have to go different ways within the cell. And while the hypothalamo-pituitary adrenal axis controls by release of corticotropin the activity of the ACTH receptor, and thereby adenylyl cyclase and protein kinase A, which then results in the expression of the 11-beta hydroxylase or the cortisol synthesizing enzyme. The renin-angiotensin system inserts via the angiotensin II type 1 receptor, which can couple not to a stimulating G protein, but rather to a GQ or GI protein, inhibiting, for instance, a potassium channel and other stuff, or releasing calcium out of the endoplasmatic reticulum and controlling, all in all, calmodulin kinase, which has similarities with protein kinase. However, stimulates the expression, for instance, of aldosterone synthase, because these promoters look a little differently, although these enzymes are almost the same. So in an adrenal cortical cell, you have two major pathways, which is the pathway exerted by angiotensin or potassium, and the pathway exerted by ACTH or called corticotropin. So this is our family, and we have a daughter which is now 18 years of age and another one which is 16 years of age. And they do have very different characters. So why that? Because both receive the signals of their parents, like, let's say, the calcium signaling, and here the protein kinase A signaling. However, this child had never had an elderly sister, for instance, while she never grew up without an elder sister. She always had a younger sister, while this child never had a younger sister. And there's a profound difference, and this is something that we sometimes seem to forget when looking at physiological pathways in tissues. So the distribution of blood is from the outer zone, the zona glomerulosa, and goes down to the inner medulla. So these cells here in the fascicular zone always receive blood enriched by waste products, for instance, in metabolism, that come from the outer glomerular zone, and so on and so forth. And that there are differences, this is something that I would like to show you. So in the glomerular zone, you have the action of the angiotensin type 1 receptor, which can inhibit via coupling to the GI protein the influence of ACTH. So in the glomerular zone, you have just the dominance of this calcium signaling within the cell. However, this receptor itself is under the control of glucocorticoids. And as you see, a precursor to aldosterone is corticosterone, which is a strong glucocorticoid, actually the main glucocorticoids in almost every organism other than human. And channelopathies or aberrations within this signaling pathway that lead to the accumulation of intracellular calcium and control of calmodulin kinase will result in overexpression of the enzyme for aldosterone synthesis and primary aldosteronism, which we call Conn's syndrome. A few cell layers deeper, the corticosterone reaches concentrations which is able to suppress the expression of the angiotensin receptor. Thereby, the lateral inhibition of signaling through the pathway of the ACTH receptor, cyclic AMP, protein kinase A is not anymore inhibited. So it can get into full function a few cell layers deeper. And this is what we call the fascicular zone. And this is because aberrations within this pathway, as let's say, cyclic AMP, which is not anymore degraded because enzymes lost their function due to mutations, or the inhibiting function of the inhibiting subunit of protein kinase A experiences a loss of function mutation, while maybe the secretory or the gain, there's a gain of function in the stimulatory subunit, will promote protein kinase A activity. And all these, well, mutations that you may develop through your life will result in the overexpression of 11 beta hydroxylase, the cortisol producing enzyme, and then in hypercortisolism, or what we call adrenal pushing syndrome. And it is irrelevant whether these mutations occur in the zona fasciculata or the reticular zone or the zona glomerulosa. If there is dominance of the say AMP PKA pathway, you will automatically develop hypercortisolism. So how does it function for the most deepest zone, the reticular zone, before the adrenal medulla? Well, there is just an inhibition, a product inhibition of the 3-beta hydroxysteroid dehydrogenase. So you cannot anymore form cortisol because there is also too much cortisol formed. And thereby you are only able to produce then weak androgens or precursor hormones of androgen and estrogen synthesis. So all in all, aberrations in the signaling through the ACTH receptor CMP protein kinase A pathway will result in hypercortisolism, while the activation of chylmodulin kinase through calcium or through mutations which within channels that activate this pathway will result in primary aldosteronism. However, in primary aldosteronism, you will also develop higher concentrations of corticosterone, and you do not have a lateral suppression of the protein kinase A pathway because you do not form any more angiotensin caused due to the suppression of renin and angiotensin. Thereby, you do not have this lateral suppression of pathway, and you also can develop slight hypercortisolism, although you have Con syndrome. This is actually recognized as a common form of secondary diabetes mellitus. As shown here, usually angiotensin leads to decoupling of the angiotensin receptor to a GI protein, suppressing the influence of ACTH. And you develop, if you develop a channelopathy, you can make aldosterone without even coupling to a GI protein. Thereby, this pathway remains open. You can form cortisol, but you do also do a vast amount of aldosterone with corticosterone as precursors, thereby advancing or promoting aberrations in your glucose metabolism. Now let's look at the different side. If you have huge amounts of glucose because you do not metabolize your glucose in your muscles, you just drive cars instead of walking, for instance, then you may develop diabetes. And if you develop diabetes, you also do recycle your glucose through your kidney, together with sodium actually. And this sodium also leads to dilution of your blood, and you have more room to collect glucose within your extracellular space. This is something, or a model, which we developed with Mika Holoitsky from the Silesia University. And this figure shows the similarities between the salt retention pathway and the glucose pathway. Both of them result in, well, an osmotic challenge and release of ADH or vasopressin and promoting thirst. And this recycling in the kidney, well, means that you will reclaim your glucose always together with salt. And on the other hand, if you develop a salt retention disorder, you will also have hypercortisolism promoting glucose pathway aberrations and diabetes mellitus, which we call the liaison of sugar and salt and the similarity between those two molecules. So this was our combined statement to the development of endocrine hypertension that you see in adrenal gland disorders, but also in diabetes mellitus. And it was a co-work between Michael Holetsky and our group, and I greet you from Rostock with this beautiful view. Thank you very much for your attention.
Thank you, Professor, for this wonderful lecture. And we have actually one question. Is diabetes mellitus secondary to Conn's syndrome other in terms of clinical image and treatment from, so to say, regular diabetes mellitus? So I guess that means type 2 diabetes mellitus.
Maybe I just missed the point of your question. I'm sorry.
Is diabetes mellitus in the course of Conn's syndrome other in terms of clinical image and treatment from the type 2 diabetes mellitus?
Well, if you have Conn's syndrome, you would like to, let's say, clarify the cause and also to remove the cause of Conn's syndrome. You would like to just do surgery before you only block, let's say, mineralocorticoid action of aldosterone. You can take away a lot of hypertension by blocking mineralocorticoids, so a medication strategy, but you cannot just get away, or you cannot control thereby the whole glucocorticoid effect. So surgery is more successful than medication.
Okay, that answers our question very well. So once again, thank you very much, Professor.
Oh, you're welcome.
And now the last lecture of this session will be presented by Professor Mirko Omejc of University of Ljubljana and will concern complete mesocollic excision for right colon cancer. Welcome, Professor, and now you may start.
So thank you very much. Let me share the screen. Okay.
Of course, we're waiting.
Okay, we are already done. Okay.
And now we can see, Professor, your PowerPoint, and we
Not
need
your
to see
presentation.
your whole presentation.
So perhaps you could share your whole screen before you start your presentation.
So
Yeah.
what shall I do?
You should click on share screen, and there should be option of sharing the whole screen.
Now we can see your PowerPoint program once again.
Yeah.
Can you see my PowerPoint now?
Yes, but we need to see your presentation.
And are you running the presentation right now or not?
Yes, it's running.
Oh.
What shall I do? It's on my screen is my presentation.
Yeah, but now, so yes, click on it, please. Like start the presentation. The slides can go. There's well, I don't know Slovenian, but I guess it should.
Tell me in English.
Yeah.
You are screen sharing, that's okay.
Maybe you should try with F5 button on your keyboard.
F5.
F5, yeah.
F5. Let me find F5. Open F5 is for voice. Not. Okay. It's surely not the correct one.
Okay, so if you look at the down right side of your screen, there is like a
Yes.
this one, yeah.
This one.
Yeah.
Click this, please, Professor.
Yes, I did it. What to do now?
Well, now we can still see your
my face, yes.
No, we can see your screen as it was before. We don't see like the presentation running. So
what shall I do? What shall I do? Hide self-view. Does it help? Remove P, no? Okay.
So maybe you should try to push the share screen, yes, and there will be more options. And one of them, the top one on the left, I believe it should be that you share your whole screen, not as the program PowerPoint, yes, now. And now try it with your presentation, the button which you used the last time.
Is it better?
No, it's not.
On my screen is my presentation, on my screen.
Yes, we know, but...
What shall I do? What can I do?
We have to figure it out.
More.
Okay, so I think that we will have to handle it this way, that you do not start your presentation like so, I mean, you don't click this button that you just clicked, and you can just switch your slides in the state which it is as you open the presentation. So yes, you have your PowerPoint opened and you can just click on the left side, you have the column which shows all your slides. So you will have to just switch them manually. Is it okay?
I don't know. You don't see anything now. You don't see my slides. No.
We see your slides, but not the presentation running itself, so to say.
Yes, we can see your PowerPoint program and all your slides.
Yeah.
You can see them.
Yes, yes.
So that means I can start.
Yeah, okay, sure, Professor.
Okay, thank you very much. But we solve these technical problems, obviously. So my talk will be about the treatment of colorectal cancer. You all know already that for the last 20, 30 years, it's one of the major problems in Europe, one of the major causes of mortality and also the morbidity after treatment. But nevertheless, there was a lot of improvement in survival, but also from a technical point, oncological point, there were great improvement, especially with introduction of minimally invasive surgical techniques. It's well known for decades that surgical resections is the only proven potentially curative modality of treatment. But this surgery must be done in that way that all primary tumor is resected together with all potentially involved lymph nodes from the drainage region of that segment of the colon. That's why it's very important for surgeons to know very exactly the anatomy of the colon, because especially vascularization of the colon, because lymph nodes, which are very important for spreading of the malignant cells, are around the vessels. Where are we now? Okay.
Professor, we decided that we have your presentation, so maybe we will just flip the slides for you, and you just have to tell us which slide we should open and when to change it.
I'm not very sure if this will run.
Yeah. So are we at the right slide, or were you?
No.
Okay.
Okay, let's go on.
Yeah.
Okay, go to the next slide. Okay, to the next slide. So it's very important for the surgery, the quality of the surgeon, because it's very well known that oncologic outcome is correlates with the quality of the surgery. So especially in oncologic surgery, it's very important that all surgical dissection are done in so-called optimal surgical plane, in so-called layer. If you remember from embryology, there is a lot of twisting and turning of the intestine in the embryological phase of development. So during this turning and twisting of the intestine, surgical planes are developed. When operating for cancer, we must open this surgical plane so that the end result is the removal of tumor together as all potentially involved lymph nodes. For colon cancer, such procedure is called complete mesocolic excision with height eye of the vessel. That means that vessels are divided at its origin. Let's go on. So how to do this? Sharp dissection should be done on the mesocolic plane in terminology which is used in surgery, so-called old fascia. That's old fascia is a thin layer between retroperitoneal and mesocolon. Let's go on. Next slide, please. And this old fascia is this loose areolar tissue which is sandwiched between mesothelial layer of mesocolon and underlying mesothelial layer of retroperitoneum. In this slide, you can see on the right side is shown as a green line. So above it, there are vessels with potentially involved lymph node. This is one layer, and the second layer of mesorectal fascia, which must not be thin, which must be incised. So it must be removed completely to prevent dissemination of tumorous cells. Next slide, please. So in this way, we can remove all the potentially involved lymph node. That means paracolic lymph nodes, intermediate lymphs, and also the apical nodes at origin of the vessel. That means complete removal with all potentially involved lymph node and safety resection margins. Next slide, please. It was well shown by many studies that when surgery is performed in that way, survival is can be improved without any additional oncological treatment from 10 to 15 in some cases also to 20% by surgery alone, and this is performed in proper proper anatomical dissection. Next click, please. But what's important, such surgery, when doing such an extensive dissection, can be dangerous for the patient and also for the surgeon, because there are numerous variations in anatomy. Let's go on. Next slide, please. There are only two constant structures in this region of the right colon. That's middle colic artery and ileocolic artery. Right colic artery can be present in about 2/3 of cases, very often in some populations even less often. But venous anatomy is even more complicated. What's very important here that veins do not accompany the arteries. So there is usually a mesh of veins which are very thin and very easy to tear, causing the bleeding during a surgical procedure. But exactly for the tumors of the right colon, especially hepatic fracture, lymph nodes in this region are very often involved. So that means that lymph nodes must be removed in order to achieve potentially curative resection. Next slide, please. So what are these most frequent anatomical variation? Ileocolic artery can run behind the superior mesenteric and can run in front of superior manual. A right colic artery, as I mentioned, can be present, can be one or two small branches. They can be in front, they can be behind the superior mesenteric vessel. One vessel may be in front, one behind, or just opposite. But even more complicated, as you see on this side of this slide, is venous anatomy. This venous drainage looks so-called Henle mesh. It's even more complicated because it drains the veins. It causes venous drainage for the head of the pancreas, but at the same time for the hepatic flexure and the right colon. So that means that branches for the right colon must be divided, but the branches from the pancreas must be preserved in order not to cause the pancreatitis after surgery. Next slide, please.
But Professor, in the version which we got, it's the last slide actually. There is no.
It's another is a video. It should be. It should be the video how this surgery is performed.
But as you can see, when we click it, it's just like closes, so we have no video. Sorry.
Oh, sorry. Can you go to my original presentation?
Yes, of course. We'll stop sharing the screen and then you can share your.
Maybe it will run this now, because it's very interesting video how this should be done. I don't know why does it not function, but it should. Do you see now my PowerPoint?
No, actually we don't see any, you don't share anything, sir, so.
Okay, let me start share screen once again. Do you see now?
Yes, we do. So you can go in, no.
You see now my PowerPoint now?
Yes, so we can, yes, you can go.
Perfect, okay, now we can go on.
Great.
Okay. You can see the video now running.
Well, the video is not running, sir, but I believe that actually it's just the image print.
It must be a video running.
But we don't see any video actually, sir. We just see the image. It's an image.
Okay, it's not possible to run this video because when I was trying to do this in test, it was running perfectly.
Well, we're sorry to hear that.
Okay, doesn't matter. Okay, that's the video showing how this surgery can be done, and all these anatomical variations were presented in video. That's why I think it's quite important to see, because anatomy very often in textbook is very simple. It's very easy to remember, but during the surgery, especially when doing this in laparoscopical way, it must be always it's very sometimes quite difficult to control the bleeding, especially in laparoscopic surgery, because these veins, which do not accompany the arteries, are usually very thin, very easy to tear. And when there is a bleeding during laparoscopic surgery, a surgeon and patients are very easily in great difficulties. So that's why all this must be prevented, and this can be prevented only by very exact knowledge of anatomical situation. I think without video, it's difficult to explain more. On my screen is running perfectly, but obviously not on your screen. It's not possible to run the video.
Unfortunately not,
no.
Professor.
Probably then I should finish, and if there is any questions about this mesocolic excision, I'm ready to ask it also without video. Do you have any questions, any comment? Unfortunately, I don't, but I think the point is to show the video, but if it's not possible, okay.
Yes, unfortunately not, but thank you very much, Professor, for your interesting lecture. As we can see, there are no more questions, so we want to thank you very much once again.
Thank you for the invitation.
And we're terribly sorry for this technical problem.
Okay. Next time we will try to find another way to show. Thank you.
Thank you very much.
Thank you.
Okay, so now we would like to kindly thank all our speakers for these amazing and valuable lectures. Now we will move on to the video presentation session of students who participated in Erasmus Plus program internships. For a moment, we will travel to the Czech Republic, Austria, Denmark, Italy, and France. We will start with experiences of Alexander Jaworski, who made an internship in Czech Republic. As we can see, there is some technical issues with the format of this presentation. So I think that we will start with another movie from Anita Froń, who participated in Erasmus Plus program mobility in Italy.
Hi everyone, my name is Anita Froń and I'm a fifth-year medical student at the Wrocław Medical University. Let me take you on my Erasmus adventure. During this holiday, I had the pleasure to spend 9 weeks in Padua, which is located in northern Italy in the Veneto region with a population above 200,000 people. This beautiful city is full of public squares, old bridges and rivers, while it also hosts the famous University of Padua with a history of more than 8 centuries and with some excellent Polish students such as Mikołaj Kopernik or Jan Kochanowski. The biggest task before my departure was finding some place to live. The university has some house of residence. Unfortunately, it is not possible to live there during the holidays. I found some private dorms, but the fee for a single room without a bathroom started from 550 euros, so I thought that I definitely can do better and cheaper. There are two main ways to find a room in Italy. You can use some websites or try luck on Facebook groups. You can find a single room even from 250 euros, but usually the fee is between 280 euros to 350 euros. I actually think it's safer to rent a room in the hotel for the first few days and then look for an apartment to rent. Speaking of apartment in Padua, you should look for an apartment nearby hospital. I live 20 minutes on foot from the hospital, so every day I had a nice walk. If you don't feel like walking, you can buy a second-hand bike for even 20 euros or rent a city bike. I definitely do not recommend areas directly near to the train station and in the industrial area. Let's move on to the University Hospital of Padova. I had to book my practical training 5 weeks in advance via the special booking page. I spent 2 weeks in the hepatobiliary surgery department, then 4 weeks in the ICU department, and I finished my practical training with 3 weeks in gynecology and obstetric department. Usually, I had to be in the ward before 8 a.m. The first thing in the morning was unit round. Then I could see some surgeries, C-section or childbirths. Unfortunately, I did not have a chance to perform any procedures except ultrasound, but I was always welcome to ask questions and observe everything, which I was interested in. I didn't have specific working hours. I usually stayed until 1 p.m. Some days I was leaving earlier or later. When I wanted to take some days off to go to a trip, there was no problem. Honestly, I can say that I didn't gain much new medical knowledge, but I learned how the Italian medical system works, how they treat their patients, and what are the differences between Polish and Italian hospitals. Now let's talk about language. Well, it would be better for me if I knew some Italian before. Not every member of a medical crew knew English, but there were always doctors, which I was able to communicate with in English. But yes, it is possible to attend the practical training knowing only ciao and buongiorno. I don't think I have to introduce anyone to the Italian food and culture. Just let me say that you can have margherita for 2.5 euros. Staying in Padova, you should definitely try the region's finest aperitivo, which is Aperol Spritz. You can have a glass of this amazing drink for 1.5 euro. And the most interesting part, trips. In Italy, you can rent a car, but definitely the cheapest option is public transport. Here are the train tickets price examples. You can also use the Flixbus. The price depends on how early you buy a ticket. The earlier, the cheaper. I also suggest the plane. You can get from Venice to Naples even from 8.99 euro by Ryanair. So before I finish, I would like to share my final thoughts and tips, and in the meantime, you can see some nice pictures from Italy. So, learn at least basic phrases in Italian. Waiters will be nicer to you. Don't order a cappuccino after 1 p.m. It's kind of a morning coffee. If you want to drink something in the evening, try espresso or macchiato. There's no X in espresso, and it's due cappuccini, not cappuccinos. Rent an apartment or room with air conditioning. Buy more than one sunscreen. Always have a bottle with you. In cities, there are places where you can fill it with fresh water. Start to think where you would like to go for the next year Erasmus experience. Thank you all for your attention.
Okay, and now we would like to come back to the video of Alexander Jaworski, who made an internship in Czech Republic.
Poland. I was asked to share some experience related with my Erasmus rotation that took part during last summer. So first of all, I wanted to say why actually I had decided to go on that rotation. For me, the biggest motivation was plastic surgery. Plastic surgery is the field of medicine that I'm most interested in, and unfortunately there is no plastic surgery as a subject at Medical University of Silesia. After 4th year of studies at Medical University of Silesia, you are obligated to go on pediatric unit and intensive care unit for internship. And surgery, general surgery, this is important, not plastic surgery. General surgery is planned after 5th year of studies. So there is no lot of time to practice and to observe some manual aspects of work of surgeons. So I thought that Erasmus rotation is the perfect opportunity for someone who is really devoted and interested in the field to get more experience and knowledge related with my personal interests. And now, why Czech Republic? As I said, plastic surgery was my priority for that internship. So I've sent dozens of emails throughout the Europe, and I got replies like, you know, you are not able to attend our award because of COVID, because of pandemic situation in our country. I got some refusals because of limitations and the fact that the priority students for some university hospitals were students from that universities, for instance. And language, of course. English is not enough in countries like Denmark or Sweden or Switzerland. And I got refusals from that countries from plastic surgery. I need to underline it because I wasn't able to speak German or Swedish or emails to the clinics located in Czech Republic. One to the clinic located in Prague and second to the clinic in Brno. And the clinic located in Prague hasn't replied to my mail to this very moment. And the clinic located in Brno replied after 3 days. And the chief of the department accepted my appearance there. So I was more than happy. And actually I was really surprised because of course I had some expectations, but what I've seen surpassed my expectations completely. I had opportunity to attend to the OR. I had opportunity to be in the ambulatory with doctors. I had opportunity to assist in the procedures, sometimes to stitch. And what was most fascinating for me, because I was able to train microsurgery in the micro lab on rat models. The department is really student-friendly, open-minded and friendly for students. And I had my own supervisor who supervised me during my practice in microsurgical lab. I really learned a lot in that place, and actually I'm planning to return there this summer. If I only be able to apply for the next Erasmus rotation, I will definitely go back there because this is a fantastic place. This is like heaven for future plastic surgeons or for students who are dreaming of this specialty. Really, really, I can recommend you not only this department, because when I was on intensive care unit, I was also impressed by the level of education and how doctors were supportive for students. So really, really, Brno is great destination for Erasmus rotations, and I can really, really recommend you to apply for Masaryk University to end the conference, and I wish you all good luck, and I wish you to apply for your dream rotation this summer.
Okay, and now my colleague Michał Hutny will tell us something about his experience from Austria.
Well, hello, my name is Michał and I'm a member of IMEC organizing committee. I would like to share with you my experiences with internships abroad. This summer, I spent 2 wonderful weeks in Kepler Universitätsklinikum in Linz, Austria. It is the second biggest hospital in Austria, and the pediatric unit where I had the pleasure to work is actually one of the reference centers in terms of SMA for this country. As you can probably already imagine, for a person like me who is interested in neurology, this place was a perfect destination for a clinical training. The staff was very competent and friendly towards me. I was asked to perform examinations, take medical history, and write medical reports. I was treated as an equal, although younger part of the team. Naturally, every interaction I had was in German. So these 3 weeks helped me improve my fluency and medical vocabulary significantly. I met very interesting patients who, together with the doctors, helped me to learn about their conditions, how to recognize them and treat them. At this point, I should probably also mention something which I wish I knew before I started organizing my first internship abroad. Hospitals in Germany often offer their trainees free accommodation and lunch during the day of work. In Linz, I had to pay a reasonable price for my accommodation in the dormitory, but at least I got to savor the wonderful meals which were served in the hospital's canteen. During the time spent in Kepler Universitätsklinikum, I met students from different parts of Austria. There were Carinthians, Styrians, and even Germans studying in Austria. You can imagine how many different dialects of Austrian German and German itself I was able to hear. It was a wonderful experience. We could exchange our experiences in terms of medicine in our countries and abroad. With some of them, I still stay in touch. The other amazing feature of the internship in Austria was naturally Austria itself. Linz is the capital of Upper Austria, which is a truly beautiful region. It is not far from Salzburg and Vienna. I was able to visit them both in the free time. We visited Vienna, Hallstatt, and Salzburg. These were very, very interesting trips, which you can easily make even with the trains. Although I personally rode to Austria with my car, but still, the train connections are very, very good. To sum up, why should you try to organize such an internship for yourself? Studying medicine in your country usually gives you an insight only into the healthcare system of your own country. You could really be surprised with the number of differences which you will start noticing during the mobility. It broadens your perspective on your future job. Perhaps in other parts of the world, it is organized differently from what you are used to. Maybe it could mean a change for the better. It is an amazing adventure where you can meet stimulating people of different cultures and make enriching connections, not only on a personal, but also on a professional level, which can be useful for your future career. Internship abroad means also sightseeing. If you choose a place on earth beautiful as Austria, you may be able to visit wonderful tourist attractions. I highly recommend participation in traineeships abroad. I can assure you that you won't regret it.
Thank you very much, Michał. And now I will share my experiences from internship I did abroad in Denmark, but we need just a minute to share my presentation and my screen. So give us a second. Okay, and hi, my name is Jagoda, and I would like to encourage you to take part in internships abroad. For this reason, I will tell you a little bit about my clinical training in Aalborg University Hospital, Denmark. I have to say in the beginning that it was not part of the Erasmus Plus program. I organized it all by myself, but I know that this hospital accept also Erasmus students. It were actually wonderful 3 weeks during which I could develop my skills and knowledge in terms of neurology. Aalborg University Hospital is quite big and divided into 2 separate buildings, the Northern and Southern Hospital. Although I have never had any contact with Danish language before, I could easily communicate with doctors and patients. You probably wonder, how is it even possible? Well, You have to know that proficiency in English is very common among Danes. Even in contact with 18-year-old patient after stroke, I was able to speak with him in English. The neurology unit of Aalborg University Hospital gave me a possibility to examine the patients with a variety of neurological disorders, ranging from stroke to Parkinsonisms. The doctors were very eager to explain the procedures to me and to show me interesting details of cases. For the first time, I was taught about differentiating the organic and non-organic background of neurological symptoms with easy to conduct in examinations. I also learned a lot about the Danish healthcare system, which turned out to be very different from what I previously experienced in Poland or in the other countries where I made my other internships. I was welcomed with politeness that Danes always smiled at me, and I couldn't help but do the same. Previously, I had no contact with Danish or pretty much any Scandinavian culture, so these 3 weeks during which I visited Aalborg, Skane, and Aarhus were a perfect way for me to get to know Denmark a bit. As much as I am a mountains-loving person, I could not resist the charm of Danish brick houses spread around the plains. The cities that I visited were all giving out this pleasant, warm, and cozy vibe. I just loved to go to the only hill in the city, overlooking the whole city center, and admire the sight of sun setting over the fjord. And well, now something about Danish cuisine. Well, I was pretty surprised because I really liked Danish cakes. And also their cuisine is very fish oriented, which is obviously quite natural considering the location of Denmark. The doctors and medical students, which I want to point out one more time, were proved to be very caring and socially aware. Denmark proved to be less financially favorable as were, for example, Germany or Austria. But if you choose to organize your internship with Erasmus Plus program, this should be not something to be worried about regarding Erasmus scholarship. All in all, I can recommend you the participation in internships abroad. It is truly a unique opportunity which will surely enrich you culturally, socially, and scientifically. You are given the possibility to experience the work environment of other country, so why wouldn't you like to take up this challenge and test yourself in this amazing journey? Thank you very much for your attention, but that's not the end. Now I would like to ask Maria Rutovic to share her screen, and we are going to listen something about her experience abroad.
Hello, everyone.
Hi.
Okay. Can you see my screen?
Yes.
Okay. So I'm Marysia Rutovic. I'm 5th year medical student from Medical University of Warsaw. And last holidays, I did my clinical internship in Nancy in France. So how did it all happen? I was doing my Erasmus program for 1 semester in Bordeaux last year. And I wanted to go there again for my holiday internship, but somewhere in May, they sent me an email that because of COVID, I cannot come. So it was very last moment to organize something somewhere else. So I went on Google Maps and just searched all the bigger cities and searched for some hospitals in there. And I was sending many tens of emails everywhere with my CV. And I only got 3 replies, and only one of them was telling me that I can actually come, and it was Nancy. So it wasn't Nancy I didn't choose Nancy. It was Nancy that chose me, and I'm really glad that it did, because it's a very, very charming small city in eastern France between Paris and Strasbourg. So it gives you many opportunities to travel around, also to Luxembourg, for example. And what can I say? Out of all of that, you have to be really, really persevere and do not give up after not getting replies, because finally you get some reply from somewhere. And how did it look like? I had to do my obligatory internship in internal medicine. So I spent there 4 weeks. And in France, internal medicine, it's not something like in Poland, because it's mostly clinical immunology. So it was really, really interesting to see all those quite rare illnesses in Poland that were all in one ward there, and how it was all organized. In France, students are like our interns after studies, and they have their own patients. They are one-on-one with a doctor, and you take care of the patients in this team of a student and a resident. So I had my own patients, and every day we had to check up on them. How do they feel? If there's anything that is changing. We were writing clinical observations on the computer, and I could do also some small procedures like salivary gland biopsies or ECGs, and some examinations when the patients were coming to the hospital. And another 6 weeks, that was the ward that I initially wanted to go to. That was plastic and maxillofacial surgery, which was quite a good opportunity for me, because in Poland, as we know, we don't really have any time during our studies that you can see really plastic surgery. And there, for 6 weeks, I was assisting in surgeries every day. And then in the afternoon, I could go to some consultations to see some patients and how do they feel after surgeries. And this was really, really cool experience, because I could see some liposuction, mastectomies, or post-bariatric surgeries. And that was really, really developing for me, as maybe I would like to do that in the future, as our previous presenter. And was it worth all the stress? Because I must admit that it was really, really stressful to organize everything by yourself, especially in this very, very short period of time that I had only less than 2 months to organize everything. Yes, I definitely recommend going on this kind of internship, because you can learn many, many things for yourself, not only those practical medical skills, but you grow as a person, because when you see that you really did make it somewhere else, in foreign country, in foreign language, it really gives you this boost of self-confidence and motivation and courage that you can take and use for some time after after coming back to Poland. And also for sure, seeing some things that you cannot see in your country, getting to know another culture. For example, me, I'm in love with French culture, so it was a really, really cool experience. And also, when you go somewhere in bigger city, there are many Erasmus students there, so you can meet people from all over Europe, and also from all over the world. And at the end, I wanted to give you some pro tips out of my two Erasmus programs. Have a multi-currency bank account, especially when you're going to France, because without it, probably you wouldn't be able to organize things like public transport ticket or some really stupid stuff, but it's really important. Search for the official city fan page websites where they post some events. Also, don't overlook the leaflets in public spaces, because they can give you some really great insight into local community and all the events. You can find some real gems there. For example, free music festivals somewhere near the city. And download the Too Good To Go app if you already don't know it. Check it out, especially when you're going abroad, and you'll thank me later for all the saved money. And also Bumble app that doesn't function in Poland, but abroad it's like Tinder for friends. So if you want to meet not only Erasmus students, but some local guys, it's really cool tool to do it. So thank you very much. And if you have any further questions, you can contact me on social media. Thank you, guys.
Okay, thank you all for sharing your experiences. And now we'd like to welcome you, Alexander, Anita, and Maria. You can turn your cameras on now. Well, Maria, you have your own still, obviously, but we're still waiting for Alexander and Anita, who are here with us for sure. We have Anita.
Hi, Anita. We're waiting for Alexander, but I think we can start anyway.
Okay, so we have questions for you. What was the reason for your choice of a place for an internship?
Yes, I don't know who would like to start. Maybe Maria.
Okay, I chose France because I speak French. And maybe I would like to go there after my studies, so I wanted to see how does it look like. And also France is beautiful. Wherever you go, you can count that you can be sure that it will be beautiful there. So
yes, that's true. Alexander, you can turn on your camera.
Yeah, we saw you for a bit, but then you switched off, so maybe.
Yes. And we have already asked the first question, which was, what was the reason for your choice of a place for an internship? Maybe you would like to answer.
Why Czech Republic?
Yes, exactly.
Okay, so as it was said in my video, my intention was to attend any plastic surgery unit because I wanted to gain some experience with reconstructive plastic surgery, because a lot of people associate plastic surgery only with aesthetic procedures. And as far as I know, all my friends who are interested or have some basic knowledge associated with plastic surgery gained their knowledge. Their knowledge was based on Instagram or just Facebook or some doctors' profiles in social media. And I don't want to say that this is fake or whatever, but real plastic surgery is divided into aesthetic and reconstructive part is like 80% of the whole field. So this is much bigger. And as I said, there is no plastic surgery unit under Medical University of Silesia, and I just wanted to observe some procedures, and I wrote a lot of emails to many countries like Denmark or Sweden or even Norway, and they all refused me because of lack of German or Swedish or whatever. I got only C1 English certificate, and it was not enough for them. And I was pretty surprised because on our website, Erasmus website, there's even told that our university, because as far as I know, you are also from Medical University of Silesia, have some contracts with Linköping University in Sweden, and I was told that this agreement is only for scientific exchange for doctors or for studies, not for internships for students. And I was really angry with it, but I couldn't do anything about it. So I just tried to find any place to attend, and I sent 2 emails to Turkey, 2 emails to Slovakia, and a couple of emails to different countries, and 2 to Czech Republic. And the clinic from Charles University from Prague hasn't replied yet, and I don't think that they will do in the future. But the head of the department of plastic surgery department from Masaryk University from Brno replied after 3 days, and he was like, there is no problem, come if you want, you are welcome, and whatever. And I just thought that I haven't had a lot of expectations. Maybe it was not okay, because I thought like this only Czech Republic or whatever, but I've never been so wrong in my life, because I don't know if you are aware of it, but plastic surgery came to Poland from Czech Republic, from Prague actually, but the experience from Prague department came to Polanica's department in Poland and to Brno department in Czech. And now this is pretty interesting that this department in Brno surpassed the level of procedures in Prague, and I've never seen so many great reconstructive procedures, like after facial trauma, after mastectomies with free flap procedures, different kind of defects, a lot of skin carcinomas. I would be able to speak about it for a whole day, and I wouldn't be able to finish. So maybe if somebody is interested, feel free to ask me on Instagram, on Facebook, or whatever you want. Feel free to ask. Just it.
Yeah, but actually it's very interesting because, plastic surgery and reconstructive surgery is not something that we hear often during our studies, right? So, but I would also like to say that I totally feel you when it comes to this rejection from Scandinavian countries. We also tried Sweden, Norway, Denmark, and, Switzerland, when we also got a lot of responses that, you don't know Swedish, so how can you do the internship? So, yeah.
Yeah, but I would like to ask this question also to Anita.
Yes, but I have to just give one technical detail here. Alexander, you're holding your phone vertically. Could you switch it to horizontal? Yes, great. Because
okay.
The transmission on YouTube is not very friendly with a vertical, so to say.
Okay, so now once again, Anita, why did you choose Italy for your internship?
Yeah, okay, so my answer will be short. To be totally honest, I was looking for a place nearby the seaside. Yeah, so Padua was 40 kilometers from the sea. So yeah, this was, to be honest, my main reason. Yeah, I was looking also for places in Spain or in Portugal. So yeah, but I chose finally Italy.
I think that's a very good reason.
Yeah.
Yeah, okay. Okay, so now we've got the second question. Did you have any fears before the mobility? And maybe now we'll start with Maria.
My only fear was that, as I said, it was everything in really last moment. And when I was going there, I didn't have any response from the coordinator. Because she was having her holidays, and I didn't get any response on which ward do I start, where should I go, So I was just going there, hoping that maybe she told some doctors from the ward that I'm coming. So that was my only fear, that they won't accept me because no one contacted with them. But I did also my Erasmus before for 1 semester, so I already knew what it was like with the language, with organization. So this time I was more prepared. But yes, when you're going somewhere for the first time, everything is super, super stressful. I must admit.
I think we had a very similar situation when we started our internship in Linz, because we didn't know exactly where we should go, and this hospital complex was very, very big. Yeah. And that was actually our first contact with Austrian German, so we didn't understand everything, and it was really, really stressful.
And the people there had really thick accents, so to say. So
thick accent, and they also speak very fast. Yeah. And with mask, it's also very hard to understand them.
Yeah, so, but we got used to that. So,
but I must admit that maybe there's a stereotype that French people are very mean, but every time they were super, super helpful. So when you're smiling and look kind of confused, everyone wants to help you. So you don't have to worry, really. There will be always someone who will help you and take you by your hand and take you to the place where you should go.
Oh, that's good to know.
The same goes for Germans and Austrians, I believe, because it's also thought that they are very strict and so on. And they are, from our experience, they were always very laid back, and they always wanted to help us, to show us something and explain. So, yeah.
Okay, so now, Alexander, did you have any fears before your mobility?
Actually, I had one major fear. It was that the English wouldn't be enough to communicate with Czech people, because the stereotype that Polish language is similar to Czech language. This is not kind of true at all, because I was able to understand maybe 50% of their national language, but this is very popular for doctors in that region. There were a lot of Slovakian doctors, and Slovakian language is more similar to Polish, and I was able to understand even more than Czech. So if there was some Slovakian doctor, I could communicate partially in Polish, partially in Slovakian, but this wasn't very confident for me, and for them, I think too. So with doctors, mainly I spoke English, but nurses or different medical parts of the crew weren't able to communicate on such a sufficient level of English. So it was sometimes difficult to communicate, and I needed to open my my mobile dictionary and to try to translate some basic phrases in Czech. But then it was pretty okay. The second fear for me was that I wouldn't be able to find myself in the city. I mean to be able to find some transport, or I had that privilege that I was there by car, because I am from Silesia region, so it was really confident for me to travel there by car. It was maybe not cheaper, but I was there for more than 2 months, 64 days, I guess. So it paid off to be there by car. I was able to travel to some places, but it wasn't my priority. My priority was to be there on plastic surgery, and I finished sometimes the day after. Once I finished at 8 p.m. So because there was like a bilateral free flap breast reconstruction, so the procedure took 14 hours. And that was my second fear. But anyway, sometimes I manage it. And I think that you shouldn't be frightened of some technical aspects. For instance, now, despite I don't spoke Czech before, I started learning Czech because I wanted to go there, and in case that I wouldn't be able to apply for plastic surgery in Poland, I'm thinking of going there because this is very, very friendly place, and of course it's not easy, but it's, I think, slightly easier than in Poland because there's no such thing like LEC or LDEC. You just need to have an agreement of the head of the department. This is not easy because there are a lot of participants in the contest, and you need to have a great CV. But I think that it's like good plan B for me to learn Czech. That was my second fear, and I think that's enough.
Okay, so it seems that internship could be also a life changer sometimes.
And what you mentioned actually is, I think, one of the advantages of doing this internships abroad, because you can broaden your CV, which is very important because, as you say, in Czech Republic, but also in Germany, you apply directly to the hospital when you want to do your specialty training. And yeah, a CV is very, very important. And yes, the same you said about Slovak and Czech language. We had similar situation in Freiburg, which is in Saxony, so eastern part of Germany. There was a young doctor from Slovakia and one older, so to say, from Czech Republic. And at one point we stood in one room. They spoke their languages, we spoke ours, and we understood ourselves pretty much fluently, right?
Yes.
So yeah.
Okay, but coming back.
Yeah.
Yes, I would like to answer this question also, Anita.
Well, so I was afraid that I would not be able to find some place to live. And if I can tell you this story, I finally found a room using a Facebook group. But when I came to Italy, I found out that unfortunately this place is not what it meant to be. So I end up in the hotel anyway. So next time I would definitely start by renting the room in the hotel. It's gonna be way less stressful for me.
Okay, thank you very much. And well, Alexander has already actually answered our third question, so I will ask only Maria and Anita. How did you handle the language barrier? Was it hard for you or not really?
When I first went to France, that was quite shocking because I had already my B2 level. So I thought that maybe it wouldn't be that hard, but local types of languages aren't the same. And when it comes to French, for example, doctors are using this more formal official one. So I understood almost everything that they were saying. But when it comes to students, they have their own specific kind of language that is called verlan, and it's totally different from normal language. And even older people, French people, don't understand younger people. So for me, it was even more complicated. So it can be a barrier, especially when you want to make friends with people at your age in France. But when it comes to like whole internship and living in France, it wasn't that hard. But yes, I had my B2 before, so it's quite a different situation when you're going somewhere only starting. And yes.
Yes, and I think that's very important what you just said, because when we are planning our Erasmus, we need to take this into the consideration. I mean, to go to the country, which language we know. I mean, or for example, we did our internship in Denmark, but in Denmark, as I also have already said, almost everybody speak English. So it was not a problem that we didn't know like any word in Danish.
Yeah.
So it's really important to think about it before the mobility.
Yes, and when it comes to France, English wouldn't work. Unfortunately, even when there were some patients that were speaking only English, I was the translator between English and French. So
okay,
when you take into consideration France, you have to really know the language.
But do you think, is it about some animosity between them, or is it like that they don't really know this language? What do you think?
I think that maybe it's not this anonymity, because maybe for older people, but those younger ones are more maybe shy, and probably they are more perfectionists when it comes to language, and they are quite afraid. Maybe they can speak or understand, but they are very shy, because, and also their accent is very, very strong. So maybe they are also shy because of this accent, and they don't want to like look stupid, especially when you are like a doctor or someone. You don't want to crush your authority or something.
Okay, yeah,
I would say.
Sure. Okay, and Anita, how did you handle with this language barrier?
Yeah, so as I mentioned in my presentation.
Sorry, I only asked if you knew Italian before you moved there to do your internship.
Not really, to be honest, only like few words. Yeah, so as I mentioned, yeah, it was not really hard to find someone in the world who speak English. So then I just followed him or her. And if we are talking about, for example, doing some shopping or going out, if you have problem, you can also, you know, just shout a little or wave your hands, and yeah, it's gonna be okay in Italy. They are just like that.
Okay, so maybe we'll ask you another question now. How were the financial issues handled by you? Was it difficult for you to, you know, finance this this trip, this internship, Anita?
Okay, so to be honest, I spent all my money given me by Erasmus during the first month. So yeah, the second month it was just on me. But I think that if we're talking just about renting a room or buying food, it's gonna be enough. Yeah, because I was traveling a lot, and I also had to buy a flying ticket. So yeah.
Mm-hmm. Okay, thank you. And Maria?
When it comes to me, I got my Erasmus money at the end of my internship. So I don't know how it works in other universities, but in Warsaw, it's not that, I don't want to say it, it's not that well organized. So yeah, you have to be prepared, and I got my money partially from my parents, and also I had my own money, but without the aid from my parents, it wouldn't be possible at all. Like I got my money to use it when I was coming back to Poland, so I didn't use it at all.
Yeah, it could be a problem sometimes. We met also two students, also Erasmus students from Poland, and they also said us that they didn't receive this money from the very beginning. I mean, just after 10 or 12 days. So they just had to live in Denmark, eat something, right? And yeah, without this Erasmus scholarship. So it can be problematic sometimes.
And do you know, is it also like this when it comes to exchange, like to study at the university for a year? Because I can say that when you think about living somewhere for 2 months, we can probably gather some money to just pay for it and then get the money from the Erasmus. But if I were to pay for 10 months prior to that, in living in Germany, that would be actually quite hard.
When it comes to this, because I was there only for a semester, so it was 5 months, but I got money after 1.5 months, I think. So, but the most expenses you have at the beginning. So, yeah, you have to have really a lot of money when you're going somewhere at the beginning, especially at our university. To buy everything, and then after 1 month I got like 70% of the whole money from Erasmus. Yeah, and I was living with it like almost till the end of my program. But as I said, like the most expenses were at the beginning, and I had to pay for it with my money. So. Yeah, my parents helped me, fortunately, but this is something that you have to be really prepared before going somewhere and start maybe saving quite earlier.
Okay, thank you very much for this answer. And as we've got 2 minutes left, we will ask you one last question. And now we will start with Alexander. Did you make any new friends during your internship?
Yes, I have some contacts with them up to this moment, but maybe I would sound a little bit brutal, but it wasn't my priority to get some friends in Czech Republic. Of course, I had some time to go out during the weekends or whatever, but during the week I was focused on work in the clinic and in training of, for instance, in that microsurgical lab, or just on this scientific part of the rotation. But of course, I was even lucky enough to find some Polish people, because I found 2 girls, one from Wrocław and one from Wrocław too. Yeah, maybe. I don't remember now, because I met them only a couple of times. But I had some group of friends. Part of them were on like rotations associated with some scholarships, but most of them were participants of Erasmus rotations exchange. So there was some. I think that it's easiest for people who attend rotations to join some Facebook groups and try to communicate and to find colleagues or friends via these groups. This most easier and confident. As far as I know, lots of my friends who went abroad by Erasmus use these groups, and they haven't complained about it.
Yeah, I think that's a great tip, actually. And well, I need to say that it's really comforting to meet people from the same country abroad. When we started our internship in Denmark, and we were for the very first time in the hospital, and the doctor started to speak to us in Polish. Yeah. That was a relief, really. So yeah, I understand it. Okay, and Maria, did you manage to make some new friends in France?
Yes, I did make some friends, but you have to keep in mind that in some countries they have holidays, and I was there in August and September, and in August there was no one in the city. So I was quite alone, but I was using this time to just get to know the city by my own. I was meeting some random people in the parks, for example. But then when September came, all the Erasmus and normal French students came, and then I met a lot of people.
Okay, that's great. And Anita?
Yes, of course, but it was mostly Polish people, I have to say. But I also gathered some Italian friends. We still have contact, so yeah.
Okay, thank you very much. Okay, so I think that our time for this session is over.
Yes.
So we would like to thank you very, very much once again. We really appreciate that you shared your experiences with us.
Yeah.
Yes, and
thank you for this valuable input. And yeah, we can wish you a great further day. And now we invite all our participants to the brief coffee break, which will finish at 11:30. Thank you all.
See you soon.
See you soon.
Thank you very much and have a nice day.
Thank you. Thank you.
Welcome back after the break. We start now with the second session of lectures and with a lecture of Professor Aneta Gawlik from Medical University of Silesia, who will present us the lecture Turner Syndrome, Multidisciplinary Healthcare. You can start sharing your screen, Professor, now.
Yes, it's okay?
Yes,
it is.
Perfect. Thank you so much. Thank you for this kind, invitation and introduction. I'm not only the worker of the Medical University of Silesia, but also the member of Turner Syndrome Working Group of European Society for Pediatric Endocrinology. So this is why I decided to present you some aspects of multidisciplinary healthcare of Turner Syndrome. I try to move on. Wait a minute. Yeah. So as a student and also as a doctor or physician, you can meet the patient with Turner syndrome at a different age of her life, stage of her life. So in a fetus, you can suspect the Turner syndrome when you found a cystic hygroma. In the newborn, you can suspect the Turner syndrome if you observe lymphedema of the feet and hands, as you see here on the picture. In the older child, you can suspect Turner syndrome in girls with short stature and lack of puberty symptoms. And finally, also in adulthood, you can also diagnose the Turner syndrome. For example, in a young woman, I think about below 40, with premature ovarian failure. So then you have also looked for other symptoms of Turner syndrome, maybe short stature, for example, as you see here on this picture. So what means the diagnosis of Turner syndrome? So not only the Turner syndrome phenotype, but also we have to confirm our suspicion by karyotyping. And of course, we can only diagnose Turner syndrome in females. So only in these patients with female external genitalia. So here you see the type and frequency of chromosome abnormalities in Turner syndrome. And as you see here, the most common is the monosomy, so 45X, so about 40 to 50%. But please look that also different types of chromosome abnormalities is responsible for Turner syndrome diagnosis. Also, about 10% of patients with Turner syndrome have the karyotype 45X, 46XY. So discussing the Turner syndrome problems, I want to show you one of my first patient when I start my work in my department. So it was the 15-year-old girl. And the main problem in this girl was the short stature and delayed puberty. In the history, we found that she was shorter since her early childhood. Her parental height was between 3 and 10, so they were also not very tall. The IQ of my patient was quite normal, and during the physical examination, her height was really below the third percentile, about 13 centimeters. The puberty stage, according to Tanner, was B1, P1. So I also found a lot of different features typical for Turner syndrome, as you see here. So short neck, maybe not web neck, but short. We can also find the cubitus valgus, as you see here, wide chest, lymphedema of the feet, and a lot of nevi, like as you see here. So we have to be very careful about the patients with Turner syndrome because they present a lot of different medical problems, like not only growth failure, but also gonadal dysgenesis. But what is the most important, we have to exclude or check for the renal dysgenesis or renal defects or cardiac malformation. So we can say that our patient with Turner syndrome can present really mild phenotype, as you see here on the left, and can also present a really strong severe phenotype, as you see on the right. So come back to our patient. So during the physical examination, we noticed the systolic murmur. We do the echocardiography and we confirm the correctation of aorta, but not hemodynamically significant. During the abdominal ultrasonography, we found the horseshoe kidney, very popular, very common in Turner syndrome patients. We also did the pelvic ultrasonography, but we didn't find ovaries. We did the karyotype, which confirmed the 45X by standard 30-cell karyotyping, and her bone age was delayed, as you see here, between 12 and 13 years. So how can we help our patient? This is the first question. Of course, we have to remember about all different medical problems in our patient, but this red frame you see here present where we are with our patients. This table presents generally natural history of medical problems in patients with Turner syndrome in different age. So not only short stature, but also cardiovascular disorders, otolaryngology problems, delayed puberty, renal anomalies, as I said before, obesity or metabolic disorders, some autoimmune diseases like Hashimoto or celiac disease, behavioral difficulties. Some in all the patients, we also observe the osteoporosis. So let's start from the short stature, because it was the most important problem in our patients. So we know that there are different phases of growing, and first we observed the mild intrauterine growth retardation in our patients with Turner syndrome. After that, we observed quite normal height gain from birth until 3 years of age, as you see here, and then progressive decline in height velocity from age 3 until 14 years, resulting in a gradual and progressive deviation from normal height percentile. So we observe no pubertal growth spurt. And finally, the adult mean height is around, without the treatment, of course, is around 140 to 146. So the adult woman is really short. Without the treatment, we know that the adult woman is about 20 centimeters shorter comparing to healthy population. Why we observe the short stature? Because of haploinsufficiency of SHOX gene. So we know that in Turner syndrome, we observe quite normal growth hormone level when we do the test, but the reason is in this haploinsufficiency of SHOX gene. So this one is also responsible for other bone abnormalities. As you see here, the shortness of the fourth metacarpal. This is one of the most common feature of Turner syndrome. How can we increase the final adult height in our patient? So first of all, growth hormone therapy, and we know the factors of good response to therapy, like longer time of treatment. It means that we have to diagnose the patient earlier. Longer therapy of growth hormone before the estradiol therapy. Higher dose. The dose is high comparing to growth hormone deficiency patients. And in some patients, by adding oxandrolone, we can also increase the final height. And I show you here the first and the most important randomized controlled trial, which the study results were published many years ago. And they, for the first time, confirmed that growth hormone therapy in Turner syndrome really increased the final adult height around the 7 centimeters. In some patients higher, in some patients shorter, but we can say that the mean growth hormone effect is about 7 centimeters. So we did the same in our patient. We started the growth hormone therapy plus oxandrolone. And as you see here, this is this red line, you see here, we observe really fast increase in height velocity during this first year of treatment. Can we do more? This is the next question. Yes, first of all, we see that in this patient, we do not observe any symptoms of puberty. So it was a huge problem of this girl. So of course, we have to start the estradiol therapy, and we did it at the same time as we started growth hormone plus oxandrolone. What we know about the puberty in our patients with Turner syndrome, we know that spontaneous puberty is up to 30% of our patients. So we observe some symptoms of the puberty in 1/3 of our patients with Turner syndrome. And this is even much more common in patients with mosaic karyotype 45. X, 46XX, even in half of them, we observe the spontaneous puberty. Half of them have spontaneous menstruation, but only 2 to 5, according to other literature, even 7% can, have spontaneous pregnancy. So we know that most of our patients need some help when we discuss about the induction of the puberty. So this is the table in which we see the preparation and dose of the estrogens which we have to recommend. In Europe, mostly we recommend estradiol. Generally, estradiol, the natural estrogen, is the most popular and the best. So you see that we start from the very low dose. About the transdermal, we start between 3 to 7 microgram per day. And during the next 2-3 years, we have to reach the adult dose. This is between 25 to 100 microgram per day when we discuss the transdermal estradiol therapy. We can also use the oral estradiol, but in my center, we prefer this transdermal. Why we prefer this transdermal? This is because transdermal estradiol, I think about the patches or gel, seems more physiological. We observe lower estrogen concentration than using oral estrogen. And of course, we remember about the first pass metabolism in the liver, that we do not have this problem in transdermal products. Patches can be cut. This is also very important because there are no special products dedicated for younger patients with lack of puberty who need the induction of the puberty. So patches can be cut, so we can also use it. And the last, maybe not the last, but one of the most important issue when we discuss about the Turner syndrome is cardiovascular screening for girls. So please be very careful about this aspect because it's important to diagnose coarctation of aorta, bicuspid aortic valve, and hypertension as a major risk factors for aortic dissection and rupture. So in 2017, Grafhold and colleagues published very good guidelines for Turner syndrome patients, and they present this algorithm. This algorithm is dedicated for younger girls below 16, and this one is for older one, and once again, cardiovascular assessment before pregnancy, before the decision of the pregnancy is very important. Why? Because special attention to the risk of aortic dissection or rupture during pregnancy, because we remember about this, that the risk of death during pregnancy may be even 100-fold higher. And the next very important aspect is the urinary tract abnormalities, which we observe in 1/3 of our patients with Turner syndrome. The most popular is the horseshoe kidney, duplication of collecting system, abnormal vascular supply. All these can be responsible for hypertension or urinary tract infections or hydronephrosis. And hearing loss. Be careful about this because we know that in younger girls, we observe the recurrent otitis media. In older, which are responsible for conducting hearing loss. In older patients, we observe the sensory neural hearing loss. So otological examination should be repeated every 3 to 5 years. So before I say thank you for your attention, I would like to present this table, these recommendations for screening in Turner syndrome at diagnosis and throughout life. I can say that Turner syndrome patients need the multidisciplinary health care, but they are not very complicated. So I advise that we can follow the last guideline published in 2017. So once again, leaving with this table. Thank you once again for your attention.
Thank you very much, Professor, for this amazing lecture concerning the very, very important syndrome that has to be recognized. And as far as I can see, we have no questions regarding this, this lecture. So we thank you very much, Professor, for joining us today. And now we would like to invite Professor Percy Knoll of Technische Universität München, who will tell us about T-cell autoaggression as mediator of liver damage in non-alcoholic steatohepatitis. Hello, Professor. We'll now stop sharing our screen and you can now share yours, please.
Hello. Thank you very much for the invitation to speak here. Actually, I would like to share my screen, if this is possible.
Yes, yes, we just stopped sharing and now you can share your screen, please.
Okay.
Yes, but I believe that what you have to do, sir, is use the share screen button, yes? And all of the options that you have in this window which opens, you should use the top left one. So the first, the one which says screen or something like that. And please do share us the screen in this way.
Let me just see how I can manage this, because I tried to do exactly this, but it didn't give me the right options here. Can I also share the program? Is this possible? Let me see. Does that work?
No, actually, no. Yeah, it's okay.
It was okay. So maybe once again, Professor, please.
Yeah. Sorry for this problem. Yes.
That's okay?
Yeah.
Perfect. Okay.
Yes, that's
then
very much so.
Let me thank you again. I would now like to shift gears a little bit from the previous presentation and introduce you to a disease which is posing an increasing problem, which is non-alcoholic steatohepatitis. And I would like at the same time, because we are a research institution, to introduce you to new pathophysiological concepts, which for this particular disease, which could lead to novel treatment options. So let me start by introducing you to the liver as an organ where you have two salient functions. One is metabolism for the entire organism with respect to protein, lipids, carbohydrates, and many others. And at the same time, a place where a regulation of immune responses happen. This is probably most prominently exemplified by the proverbial transplantation tolerance of after orthotopic liver transplantation. So the place actually in the liver where all this happens is a unique microanatomy, because the liver, in effect, as you see here in the corrosion cast in the upper left corner, is a huge macrovascular sponge. And if you look closer, then actually this vasculature is defined by these endothelial cells in the liver that line the hepatic sinusoids, which are the microvessels of the liver. And these sinusoids are populated with all kinds of immune cell populations, like the macrophage population of the liver, Kupffer cells, but also T cells. And then you have all the other subpopulations that the liver is famous for, like hepatocytes and stellate cells. So the disease I would like to talk about today is called non-alcoholic fatty liver disease, or as an abbreviation, NAFLD, that can actually go on to an inflammatory state, which is then called non-alcoholic steatohepatitis. The incidence of this disease is rapidly increasing worldwide. I've taken the liberty to show you here an overview of the entire world, depicting the incidence of NAFLD. The transition actually to NASH is about in a third of the patients. So you can clearly see that this is going to be a problem. The forecast is that in about 15 to 20 years from now, liver disease resulting from any other cause will be in the minority compared to liver disease resulting from NAFLD and NASH. The histological features of this disease you see here, it's this fat accumulation in the liver, which is called steatosis. And once you go into this progressive state where you have inflammation, you see then that there are immune cells that come to the liver and cause actually liver damage. And if you look at the time axis, where this happens in a matter of 10 to 20 years, this develops from benign steatosis to NASH, to liver cirrhosis, but also to liver cancer. So it's a disease that we have to take very serious, and for which there is no causal treatment at the moment. So the causes of these are manifold. I will not have time today to introduce you to all of these ideas, how it could develop in detail. But I want to make it clear that the immune cell populations that are actually localizing in the liver are a major driver of these changes in the hepatocyte, but also in these stellate cells that are responsible for the development of liver fibrosis and liver cirrhosis. So what is the role of these immune cells in NASH? And we have tackled that, and I would like to guide you through these results step by step. So it will be a little bit more of the research that you are exposed to now. So we used a preclinical model of this disease that occurs in man, which is by feeding these cells a high-fat diet, typical high-caloric diet, in a combination with a choline deficiency, which is very often observed in patients. And what you see here, that's a preclinical model. So it's mice that have become obese and developed NASH that, as you see here in these black bars, that now if we take away one immune cell population, which is T cells, from these animals, that actually these animals don't develop liver damage anymore and are spared also from severe consequences of liver disease. So raising the question, why should T cells as part of the adaptive immune system contribute to NASH where we don't have a pathogen that could be responsible for triggering adaptive immunity in forms of T cell activation? So we looked closer into this and we found that actually in the liver, there is an accumulation in these animals that developed NASH that showed an accumulation of a particular population of T cells, which were CD8 positive, which qualified therefore as effector T cells. And when you look by confocal microscopy, this is technology where we can look into tissue and do also 3D reconstruction. So to really see how the relation of these cells are, we find that these cells, which we talk about, are depicted here in yellow, are really scattered throughout the liver. So they are not only in certain places, but they are really scattered throughout the entire liver. So we can actually isolate these cells by particular technologies and then interrogate what defines their particular state, which is called an RNA sequencing. So we look at the transcriptional program that is present in these cells, and we found that these cells have a unique transcriptional program which could be compared to a situation where you hit the gas pedal and the brake in a car at the same time. So we asked ourselves, what is behind this? So why are these cells doing this crazy thing, accelerating and braking at the same time? And we did something which is called a transcription factor analysis using bioinformatic tools. And what you see, what you can do nowadays with this is to identify the key transcription factor that is on top of this entire hierarchy, which we identified to be a transcription factor called FOXO1, which is important for metabolic regulation in cells. So we took this further and isolated the cell populations that we could now actually identify through various biomarkers and examine their functional features again under in vitro conditions. And what we observed is that these cells actually killed innocent or bystander cells. So cells that would be in the vicinity of these T cells would be killed. That's why we termed these cells autoaggressive. And importantly, I'd just like to point your attention here to this graph, is that in the absence of MHC class 1 molecules or HLA class 1 molecules, which are normally important to inform T cells about presence of, for instance, a foreign antigen or an infection with a virus, that this molecule is dispensable. So it's not required for this activity. So when now we looked closer again into liver tissue, we found that these CD8 T cells that were in the liver, that we found in the liver, they were in the direct vicinity of hepatocytes that are shown here in red, that are undergoing cell death, which we can identify through an activation of a so-called effector caspase responsible for triggering cell death. So we can conclude from this that T cells with this particular phenotype seem to kill hepatocytes in these during this particular disease process in NASH. We then took the knowledge that we gained from this bioinformatic analysis and looked whether patients would have the same population of T cells. And indeed, we identified a population which has this particular transcription factor here as a biomarker, and they shared many of these peculiarities that we found also in the preclinical model. And then to put this into perspective, when we now compared this unique way of how T cells can kill their neighboring cells, we found that this can be prevented if we impair certain signaling processes on the surface of T cells. For instance, here a purinergic receptor, or if we block release of certain metabolites from the hepatocytes. But in contrast, when we looked at the typical T cell activation, which is recognition of antigen presented by HLA class 1 molecules, neither of these inhibition steps actually impaired the normal specific cytotoxicity of antigen-specific CD8 T cells. So demonstrating that we have identified a unique way, a novel way, how T cells are activated in tissue in metabolic diseases, and that this is fundamentally different to the normal T cell activation. So this gives you a summary of what I've just told you, that there are different stages of this process whereby T cells actually contribute to liver disease, which is an initial activation state, then a state where this receptiveness of the cells to execute autoaggression is amplified through different steps like short-chain fatty acids released from hepatocytes, and then the induction of this execution of autoaggression by metabolites like extracellular ATP, for instance, signaling through these purinergic receptors that I just mentioned, the P2X receptors. And this is actually responsible for liver cell death. So this identifies a novel and so far unknown role for T cells in immune-mediated liver damage. And obviously it will lead the way to identify molecular targets for therapeutic intervention. In an accompanying article in the same issue of the journal, we identified that this actually explains also the non-responsiveness of liver cancer that develops in these patients to the typical checkpoint inhibition that is used nowadays. And it will therefore serve as a good platform to develop novel immune therapies for this type of cancer. So again, this is something which is what we identified here is a very specific process which discriminates the typical activation process for antigen-specific T cells in the presence of inflammation and release of certain metabolites that we have this immunopathology through a metabolic T cell activation that induces autoaggressive killing of bystander cells. And I'm stopping here and want to acknowledge all the people who contributed to this, and I'm looking forward to your questions. Thank you.
Thank you very much, Professor, for your wonderful lecture. And we've got actually one question for you.
Yes. Are these T cells, which are involved in the inflammation, lead to development of non-alcoholic steatohepatitis, are they under the control of these regulatory T cells? Can they be controlled using, so to say, the conventional immunosuppression, or can't we stop this process in this way?
That's an excellent question, which we have not addressed yet. It is, however, not very likely that this is possible, because also these regulatory T cells would be killed by exactly these autoaggressive cells, which we have observed because they kill everything that is in the neighborhood, irrespective of what the cell type is. So it's hepatocytes, endothelial cells, these stellate cells, but also colleagues like other CD8 T cells or regulatory T cells. So unfortunately, the answer to this is that there is no way how we can stop them by using our conventional technology. So we have to seek for new ways how to stop it. Excellent question.
Thank you very much, sir, for this answer and for the whole lecture. Once again, we have to admit that the acuity of your dog is excellent.
Thank you very much, sir, once again.
Yes.
And now we are going to play a video. Actually, it's a lecture from Professor Blas Mawczyc of University of Ljubljana. The title of this lecture is The Role of Hip Arthroplasty, registries and cohort studies in orthopedic surgery.
Dear fellow students, dear fellow doctors and future doctors, I thank you for having given me the opportunity to present my views on the role of hip arthroplasty registries and cohort studies at your international conference in Katowice. Total hip arthroplasty has been performed for the last 60 years, and it has now become one of the most successful surgical procedures in orthopedic surgery and in medicine generally. It has gone through evolution of several different surgical techniques, of different fixation on how to fixate endoprosthesis components into the bone. It has undergone different implant designs and ever-changing rehabilitation protocols. Although it is now a common operation, and in most cases it achieves excellent clinical results, this is not always the case. And in most cases, patients have durable outcomes with functioning total hip arthroplasty for over 15 years, but again, this is not the case in every single patient. Artificial hips consist of implanting a metal femoral stem into proximal femur that communicates with acetabulum. Historically, these implants were implanted into the bone with bone cement, but in the last 2 decades, most present total hip arthroplasty implants are fixated with uncemented fixation by directly press-fitting metal into the bone. In the femoral stem, we have a long metal implant implanted into medullary canal of the proximal femur, and then a ceramic or metal head is attached upon this femoral stem, where it communicates with acetabulum. On the left side, you can see what this looks like during the operation. On the acetabular side, we can have partial or total hip arthroplasty. In partial hip arthroplasty, we have only femoral side replaced, whereas in total hip arthroplasty, we put in a polyethylene liner directly into the acetabular bone, as shown here on the right side, or we use a cementless metal-backed implant to substitute our diseased acetabulum. So if everything is so perfect as shown in previous pictures, what is then the problem? Surgeons mostly perform their work well, and patients in most cases are happy in the beginning, but unfortunately all endoprosthesis will eventually loosen in the bone at some point in the future. And if we want to follow up the quality of our health service, it is not only important to know how well the patient is today, but it is more important to know how long this will last and what will happen in the future. How can we address this problem? At present, we can assess the quality of total hip arthroplasty with patient-related outcome measures that include subjective pain scores or functionality measurements, objective scores, or range of motion measurements. However, we don't know or we cannot predict how many late infections, fractures, or luxations a certain implant will produce, and likewise we cannot know how many of these endoprostheses may loosen in the next 15 or 20 years, as is the normal expected lifespan of an implanted total hip endoprosthesis. If we want to systematically follow up the results of our arthroplasties, we need a cohort study. Cohort study is a subtype of longitudinal study where we define a group of people who share a common characteristic, for example, implanted total hip arthroplasty with a certain implant. We then follow up participants over a period of time, and we can do this either retrospectively or prospectively. This is an image where our cohort is formed from population by being exposed or non-exposed to a certain implant or to a certain surgeon. And then afterwards, several decades later, we can assess whether a certain event, for example, endoprosthesis loosening, occurred or did not occur in an observed amount of time. The main point of interest after total hip arthroplasty will include how well the patient can walk, how much pain reduction we achieved, how long will he remain infection-free, and how long will he remain pain-free. But most of all, we will want to know whether the loosening of endoprosthesis will require some future reoperation or so-called revision operation. And how long will it take to require the next revision? As we mentioned previously, we expect most total hip endoprosthesis to last at least 15 years. In order to get a longitudinal quality control all over hospitals in one country, some countries started introducing arthroplasty registries as early as in the 1970s. Sweden was the first country to introduce these registries, and later Nordic countries, other European countries, Australia, New Zealand, and USA also followed. Arthroplasty registries pool data from all hospitals in one country, and thereby this healthcare system data is quite abundant. We can get data on more than 100,000 people in one country of 4 million, for example. These large numbers of cases can then be stratified by patient's age and implants. However, because it is very abundant to collect such amount of data, most arthroplasty registries do not take account of confounding variables like hospital, femoral head size, surgeon, gender of the patient, or collinearity between surgeon and implant. That is, the habit of one surgeon to perform one implant, and then we don't know if good or bad results are the results of the implant or the surgeon. Arthroplasty registries have contributed a significant amount of important data to our scientific publications. For example, in Australia, it turned out that cemented and cementless implants may be equally good in overall population, but it turned out that in younger patients, cemented implants don't do that well when we look at them 8 or 10 years after the implantation. Similarly, a Norwegian arthroplasty registry has identified a problematic bone cement in 1997 that later had to be withdrawn from clinical use. Or Australian Joint Replacement Registry was the first institution to point out failed femoral neck breakage in certain femoral implants that later had to be removed from the market. So arthroplasty registries are very useful, but they ignore one important confounding factor, that is the surgeon. Because some procedures may require more skills than others, and some surgeons are more skilled than the others, arthroplasty registries only give us results of the so-called average surgeon. However, we don't know whether this implant would be equally good when used by more skilled or less skilled surgeons. If we want to find what happens when different surgeons implant the same implant, then it is more useful to apply hospital cohorts. Hospital cohorts include patients from the same hospital who were operated in a uniform environment with uniform local doctrine as of thromboprophylaxis or rehabilitation. Of course, in this way, the number of patients included is much smaller than in whole nation registries. However, we have more data per patient, and we can stratify patients by implant and surgeon alike, and not merely rely on the age and gender of overall patients. For example, at our hospital, University Medical Center in Ljubljana, we were able to gather data on almost 2,000 cementless endoprostheses that have been used for 26 years, and we found that there was significant variation in final outcome and implant survival depending on which surgeon did the operation and what season of the year the implantation was occurring. Likewise, we were able to follow up cemented implants Link SP2 for almost 33 years in the amount of 3,000 included cohort patients. In this particular implant, we found no statistically significant variability between surgeons. However, patient's age was an important factor that contributed to lower odds of subsequent implant removal. Therefore, to conclude, both arthroplasty registries and hospital cohorts are important scientific tools to assess the quality of our work in a longitudinal way. Arthroplasty registries are very useful if we want to know what happens with a certain implant in the hands of an average surgeon when used on an average patient. However, if we want to identify variability between surgeons or variability between patients, it is more useful to use hospital cohorts. In conclusion, I would like to emphasize the importance of these findings beyond the field of orthopedics. As you know, as students who do research work, you may have found that even for observational studies, it is required to obtain ethical approval of some institutional review board. But I would like to pose a provocative question. Is it, on the other hand, ethical not to follow up patients systematically and longitudinally? I think as doctors, we should strive that every patient would be invited in some sort of study, because it means that we care about improvement of our healthcare services and we care about the quality of our medical work that we do. We should be aware that quality of medical work does not happen accidentally. It requires planning and resources and follow-up. Thank you for your attention.
Okay, and now the lecture for those of you interested in psychiatry, so in that case also for me, Professor Benedicto Crespo-Facoro of University of Sevilla would tell us about biomarkers in schizophrenia and what they mean for treatment. Welcome, Professor, and you can share your screen now.
Okay, thank you so much for the invitation. It's my great pleasure to be here with you, and I hope that the lecture that I will give you is of interest for all of you. Let me start by sharing the full screen. Well, I mean, I would like to share with you the notion that nowadays in schizophrenia, in general, in mental health illnesses, we need to combine clinical and basic research, experimental research, right? Because, I mean, if we look at what happened to our patients, it's clear that we are facing a very, diverse, the diversity of the presentation and also the outcome of our patient. And this is especially relevant for schizophrenia. This is my statement of potential conflict of interest, since I will talk a bit of antipsychotics. As I was saying, that it is important to recognize that in schizophrenia, one of the major features of the illness is the heterogeneity of the patient that we see. The heterogeneity is just not only observed in the severity of the clinic, but also regarding to the age of onset. Some of the course of outcome characteristic related to functionality, but especially related to the treatment response that we see in our patient. That is, that there is a huge variability between among patients regarding, who respond well to the classic or the routine antipsychotic that we use or do we have in the market. And to address this heterogeneity, we think that it's important to move on in the knowledge of a biomarker, which the different variables that we can use to predict or to subtype the entire sample of patient and classify them into different subtyping. You mean that, I mean that if we will success in this task, we will be able to give the right treatment for the right patient from the first stages of the illness. So we focus in our research to try to address or try to move forward in this field of the treatment response to antipsychotic in first episode psychosis. how did we do it? I mean, there are two major routes, so two major channels to do that. The first one is the most typical one is the looking for in the phenotypes, and the phenotypes are, you know, should be some a clinical or characteristic that should be related to the genetic basis of the illness. At the same time, it should be closer to the gene than to the clinical phenotype. So that's the main definition of endophenotypes. And in the other side is what we call a biomarker. Biomarker is a characteristic that is, but it's not related to genes. It's related to one a clinical feature of the illness of the patient, right? So, I mean, we should look for this variable, which is a biological variable that should be affordable, also accessible to many of the clinics in the way that it should be used for all the clinical settings, and also should be easily measured. But the key issue when we are looking for biomarkers is that it has to be relevant to one clinical outcome. I mean, one clinical major question regarding the illness. I mean, something like can this variable shed some light in the way to help people to identify good or poor cognitive outcome, for example, or in our case, can we define any biomarkers related to a good or poor clinical response in our patients? So biomarkers can I mean, we can obtain the biomarkers for sampling coming from peripheral tissue, I mean, plasma or lymphocytes or cerebral spinal fluid, but also from central biomarkers coming from the brain, or some indirect measure of the brain, that's the imaging of functional or structural neuroimaging. And from there, we use this to address one of these type of biomarker that I'm saying, I mean, related to the diagnosis, monitoring, prediction, or I mean, talking about the prognosis of the illness, of the safety, I mean, some side effects related to the use of antipsychotics. And then we are able to link this and this biomarker to one of these clinical response. So this is the major issue. So what we have done in our lab is trying to link this biomarker using some of the omics. I mean, in this the issue that I will share with you today or show you today is regarding to pharmacogenetics or transcriptomic data from peripheral blood, right? So this is our approach. I mean, it's possible to dissect the molecular basis of antipsychotic. I mean, when we are using antipsychotic to control the acute symptoms of our patient, I mean, it's possible to define what's the molecular pathways, what's going on inside the cytosol, and how is the transcription of some of the genes that will be controlled for this antipsychotic. This was our major hypothesis at the beginning of the different research that I will share with you. The first one that we did is just to come from human sample. That's important in the combination of data, as I told you at the beginning, combining data from human research and experimental or cellular or animal models that I will show you later on. So the first step was trying to see what happened in patients when we were comparing the gene expression of people with the first episode of psychosis, drug naive. They had not received any dose of antipsychotic when we get the blood sample, and compare the expression of the gene, the transcriptomic of this, the gene expression panel of this patient at baseline, compare to the same set of patients after 3 months when they show a good clinical response. I mean, they show a decrease in the severity of the symptomatology after 3 months using antipsychotics. So we did this direct comparison, and we obtained a list of genes that were differentially expressed at the beginning, at baseline, compared to 3 months. That means that these genes were modulated, they were controlled. The overexpression that we see at the beginning, this overexpression was controlled by the antipsychotic after 3 months, and these genes show a decreased expression after 3 months, and this decreased expression was correlated to a decrease in the severity of the symptomatology. I mean, it was they were related to a clinical response of the genes, right? The first gene was ADAMTS-T2. ADAMTS-T2 is a metalloproteinase, and it is related to to maintain the structure and functionality of the extracellular matrix. I mean, you know perfectly that in the synapses area, there are 4 part, which is the presynaptic, postsynaptic, which is the glia, and also which is the extracellular matrix, which is, you know, which is overall trying to cover all the other 3 parts of the synapses. Well, so we analyzed these 6 genes, and we came up with the conclusion that if people show a decrease in blue level of expression of these 6 genes, these 6 genes were related to the clinical response to antipsychotics. So we call this set of genes related to a good response. I mean, clinical response genes to antipsychotic, right? I mean, we published this. And then the second question that came to our mind was, okay, well, how is the pattern? What is the map of expression of these genes in the brain? Because I mean, if these genes that we identify using human sample, human blood, I mean, if these genes were not expressed in the brain, I mean, it doesn't make, you know, these genes could not be related indeed with our major goal, which that was to show that the modulation of this new target for the antipsychotic. But it was a bit striking for us that this gene, especially the ADAMTS-T2, the metalloproteinase ADAMTS-T2, was overexpressed in the brain. You see the Euroexpress data set, and that's a mouse brain, and you can see at the embryo age of 14.5 that the expression of the gene is in the hippocampus, in the dentate gyrus, but also in the ventral tegmental area, and also in the I mean, that it was really motivating, encouraging for us to see that the genes that we identify in human, they were also expressed in the brain and in regions that are really involved in the pathophysiology of schizophrenia. So the third step was to look at the animal model of schizophrenia. This is a collaboration with people at the University of Virginia, the Commonwealth University in Virginia, United States. And we did it just to use the animal model, which is just to submit the mother with the influenza virus, and then just to check if the offsprings, they had symptoms or behavioral abnormalities that remind us to schizophrenia, which is a schizophrenia-like mouse, and see what is the expression of this in these 2 brains, which is the expression of the ADAMTS-T2 and the rest of the clinical response genes in the prefrontal cortex. And also, I mean, it was some kind of striking and unexpected results that show that these genes were overexpressed in the prefrontal cortex of this animal with a schizophrenia-like model. So we said that we coming from human, we realized that these genes were expressed in the brain in important regions, relevant regions of the brain related to schizophrenia, and also using an animal model of schizophrenia, we demonstrated that these genes were overexpressed in the prefrontal cortex of the animals with schizophrenia, the schizophrenia-like animals. So we moved forward and we tried to verify it. I mean, we tried to corroborate our model using cells, which is a molecular model of the effect of antipsychotics controlling the expression of this metalloproteinase, which is the T2. So we did an experiment using an independent sample of humans, try to see where is the expression, I mean, what is the expression on Adams T2 in peripheral blood cells in comparing patient and control. And again, we demonstrate that there was an overexpression of the gene in schizophrenia patients compared to, in schizophrenia control compared to controls. And also after 3 months, we showed that, we were able to decrease, to control the expression to levels compared to the not control levels in this sample of schizophrenia. Schizophrenia overexpressed after 3 months, it was controlled the expression. So we did also an experiment trying to show how the different antipsychotics, the clozapine, haldol, haloperidol, aliperidone, or aripiprazole can control in cell culture, can control the expression of this protein, of this gene, or the Adams T2. And we demonstrated that using clozapine, and especially clozapine and haldol, we were able to control the expression over time. After a very complex, this is a paper that we published in Translational Psychiatry. We were able to show, I'm not going into in detail because we don't have time, but we were able to show what is the mechanism, the molecular mechanisms that it can be affected by the antipsychotic, especially using the control of D1, the dopamine receptor 1, and how is the pathways of the molecular pathways going through adenyl cyclase and the PKS, the phosphokinase A, and controlling the expression of the Adams in the nucleus. So our main goal was to demonstrate that if we can control some of these targets involved in the pathways, in the molecular pathways, signaling pathways of the effect of the antipsychotic, probably this can be a good target for new compounds to control the symptomatology of the illness. So we demonstrate that probably using the pathways, we can come with a new repurposing or new compounds to be used as antipsychotic in the field of schizophrenia. Well, it is important for just to make a 3 major reflections about our research. It's important to come from human cohort, but also combine with animal and cellular models to move forward in the field of schizophrenia, in the field of mental illness research. It's important to know that to have a good validity of a given biomarker that could turn in endophenotypes, if we link this to a genetic basis, should be, it's a large path, and also, some should be reevaluated, continuously reevaluated, and also it's important to integrate all this state-of-the-art methodology to move forward in the field of the mental illness of schizophrenia. Well, thank you to all my team. Young people doing excellent work. Coming from clinical settings or from the lab. Molecular biologists or animal models people, and also all the agencies that help us funding our research in the present, and also I hope in the future. That's all, and thank you so much.
Thank you very much, Professor, for this excellent lecture on the, so to say, frontier of psychiatry and genetics. Unfortunately, due to the complexity of your lecture, we're left with no time for further questions. Nonetheless, we thank you very much once again. And as a closing mark of the second lecture session, we would like to invite Dr. Piotr Spychalski to give an insight into new horizons in colorectal cancer surgery. Thank you for joining us, Doctor, and now you may start with your presentation.
Okay, hello everybody. Give me a second to start it up. We have it?
Yes, we can see it. Thank you very much.
Okay, thank you. Hello again, my name is Piotr Spychalski. I'm an assistant and a resident surgeon at the Department of General Endocrine and Transplant Surgery at the Medical University of Gdańsk. To the opposite to the previous lecture, mine will be maybe a bit more general to give you an insight into how we at the moment think about surgical approach to colorectal cancer. And this is what it's gonna be about. These are my conflicts of interest, and going to the topic. Treatment of colorectal cancer is combined of three major steps. It kind of depends whether we are speaking about colon cancer or rectal cancer, which are a bit two different entities, but the general concept is the same. The first step towards treatment and possibly even curing this cancer is either screening or diagnosing people with symptoms. And in this area, we have pretty quite good evidence in what is effective, what is not, and how it should be done. We have few approaches, including FOBT and FIT tests and colonoscopy to diagnose symptomatic patients or to perform screening in asymptomatic populations. We have high quality evidence, we have high quality guidelines which tell us exactly how to do it, what is good and what is not. Then in some cases, especially in rectal cancer, we have neoadjuvant treatment. It's been proven that neoadjuvant treatment in locally advanced rectal cancer improves overall survival, which is why we do it. And again, we have good evidence. We have a lot of research going in. This research is rapidly introduced into clinical practice. An example of that is a recent trial called Rapido, which explored different approach to pre-neoadjuvant chemoradiation or radiochemotherapy rather, and it was really introduced into clinical practice just after being published. It's already known that in rectal cancer after neoadjuvant treatment, up to 15% of patients will achieve total complete pathological response in the specimen after excision. So in these patients, we excise the specimen, we excise the rectum, and we find no cancer. The pathologist finds no cancer. The treatment, the neoadjuvant treatment, is so effective at the moment. We don't yet know which patients should be will benefit the most from neoadjuvant treatment. It's possible that in the future we will only give neoadjuvant treatment, which will then be the proper treatment, the main treatment, and it will be enough for them. They will not have to be operated, but that's at the moment only a speculation and a possible horizon for the future. At the moment, we still have to operate everybody according to the guidelines. And then we have the surgery. And one could argue that surgery is kind of the weakest link of this process because we don't have many guidelines, we don't have good research. It's not entirely surgeons' fault. It's quite hard to perform good research in surgery because of the heterogeneity of situations in surgery. And also because there's not much new to do. although we still have few questions, we still are not sure how to prepare patients, how to treat them preoperatively and postoperatively, which surgical technique to use, when to discharge them. We don't have many standards and guidelines, and the practices over our country and over world are quite heterogeneous. And then we again have adjuvant treatment for patients who require it, and the situation is quite similar as with neoadjuvant treatment. Oncologists, medical oncologists, and radiotherapists are very precise people, and this is obviously a compliment, and they have everything mapped out in guidelines and in research, and they do it just as it should be done. Going over the further steps in screening and symptoms, we have mainly at the moment colonoscopy. Many countries use FIT, and especially FIT screening tests, but if it's positive, patients are referred for colonoscopy. Sigmoidoscopy lost its place or is losing its place because there are too many cancers in the right part of the colon, which is why we prefer colonoscopy. And colonoscopy nowadays, it's not only a diagnostic modality, it's also a treatment modality. Obviously for colorectal adenomas, which are precursor lesions for colorectal cancer, but also for local colorectal cancers. Cancer in situ or cancer in T1 stage can be treated with colonoscopical modalities, and I will get back into that. So in the second part, we have the neoadjuvant treatment. I've spoken about Rapido for a second. It's being discussed at the moment still, but the idea I want to sell you is that in oncology, we have quite a lot of research, and it's being strictly monitored by practitioners, and they are introducing new evidence if it emerges and if it's good to provide it for patients. So it's working very well. And then we have the surgery, and surgery is still an issue. And there are multiple reasons for why surgery is an issue. First of all, in modern treatment, modern surgical approach, everybody should be aware that it's all about the team that's treating the patient. It should be a multidisciplinary team with a lot of specialists who are making decisions together with patients' perspective at their heart, and there is no I in team. You probably have seen it, although there is an I in the a-hole. There is a joke going about it, and unfortunately it's quite often that the surgeon is that a-hole in the team who is thinking that he's the most or she's the most important, and the decision is most important, and the surgical treatment is most important. And it's not exactly true anymore. So we as surgeons should be part of a multidisciplinary team, which consists not only of colorectal and hepatobiliary surgeon, but also of radiation oncologist, gastroenterologist, medical oncologist. We should have patient at our hearts, and also we need a case manager and a stoma nurse in colorectal multidisciplinary treatment. And this has been confirmed in research and in guidelines. And even though it's been confirmed, it's still not the standard of care everywhere, which is kind of an issue. Although, fortunately, at my department, at my hospital, it is the standard of care, and we are doing it this way. We have a multidisciplinary center for treatment of colorectal cancer, and it is something that is being more and more popular both in Poland and worldwide to create these units for treatment of a specific disease, such as breast unit or breast cancer unit or prostate unit or colorectal unit and so on. And we are going in the same direction as well. Fortunately, our country, and maybe surprisingly, is also giving incentives to do it, because the system of financing at the moment is promoting hospitals which are focused on the care of a specific cancer, and they are doing a lot of treatment of this cancer. You have to know also that the surgery is not an operation. Surgery is a bigger thing than an operation. Operating technique or an operation is only a short period in patient's care, a short 2 hours in the entirety of their lives and the entirety of the treatment. And surgery is more about more things than only the operation. The operation is obviously crucial and it has to be performed correctly and adequately, but it's not the only thing that surgery is about. Surgery is about the operation, obviously, but also about the coordination of care, the prehabilitation to sustain the surgical treatment, to sustain the operation. It's all about the hospitalization and how we do it, how we care for the patients when they are at our hospital, and it's also about the rehabilitation after the operation. When I'm meeting my patients in hospital or outpatient clinic, all of us, when we are meeting them and we are explaining them what will be happening during hospitalization and treatment, we are explaining to them that an operation is like running a marathon. And a person does not go and run a marathon without any preparation. So we are telling them that they have to be prepared and they have to work for being prepared before the operation and the prehabilitation period. This is all in line with ERAS, which is enhanced recovery after surgery. It's a trend in surgery which is focused on improved recovery post-surgery. It consists of pre-admission, preoperative, intraoperative, and post-operative care, and it's a variety of small interventions which are supposed to reduce the injury to the patient and improve the recovery after the surgery. And this is something we are doing in every type of surgery and colorectal surgery as well. Another part is coordination. Coordination has also been proved to be beneficial for the patient, especially in cancer care. And and not only we, most novel places that treat cancer have a specified person who is a coordinator for the patients, and this person is focused only on providing them the technical assistance in the course of the treatment. In Poland, it has been it's been improved now thanks to the DILO. DILO requires. So it's a system of care for all of the cancers, the DILO program, and DILO requires you to have a DILO coordinator. And thanks to having such a person, we have a minimal loss to follow up. We have less visits in hospital or outpatient clinic because this coordinator plans the visits in such a way so the patient has to visit the hospital site a minimal amount of times, minimal number of times, and they are kind of putting together all of the visits into one day if it's possible. We have shorter diagnosis time, and we have careful post-op follow-up, and this is also a good person for families and patients to be in contact with. Then we have the prehabilitation, and it's also been proven that it's beneficial for the patients. We are advising patients prior to operation to start exercising and improve their diet, increase the amount of proteins in their diet. It's known that sarcopenia is a risk factor for surgical complications and even mortality. You have to remember that normal BMI persons or even overweight and obese BMI persons can still be sarcopenic. As you can see, 16% of overweight or obese and 30% of normal patients are sarcopenic. Sarcopenia is a major risk factor, so you have to remember that patients have to exercise prior to treatment because the muscles are the actual reserve for post-operative period. The fatty tissue isn't exactly a reserve because it's only an energetic reserve. It does not have proteins in it. And post-surgery, a person is in a severe catabolic state and needs protein reserves. It's especially of note especially important in patients who are post-GI tract surgery because the GI tract function is not the same after the surgery. It's also often quite delayed. Prehabilitation is being researched, but still not very extensively. It's changing. although we know that it's important and it improves outcomes. As you can see on this forest plot, it reduces time of hospitalization in every study. Here we have time of length of hospital stay. Here is the baseline, and if the prehabilitation was used, it reduces the length of stay. Okay, we advise patients to exercise, and that's the second part of the prehabilitation besides nutritional assistance. We educate them on the topic of stoma, and we explain to them that it's possible they will have to have one and how it is performed and where will it be. It reduces the stress and increases the acceptance rate of having a stoma and caring for it. And it also has been proven that it should be done, even though it's still not a standard everywhere to educate patients in stoma. Then we have the hospitalization, and one of the things that a modern surgeon should do in case of hospitalization, they should prepare the patient before the operation for the surgery. Fasting is no longer a good choice. We know that we should provide carbohydrate loading similarly to sportsmen that are doing marathon runs or triathlons. Our patients are doing carbo loading before the operation. And finally, we have the operation, and the operation is an important step which has to be done adequately, because adjuvant treatment cannot rescue patients from poor quality surgery. So the surgery has to be adequate and high quality, although it's only a small part, a small 2 hours of the whole process. There is not much new things going around at the moment. Everything has been already researched and done. Obviously, we have a lot of tools in surgery. We have high energy devices, we have staplers, we have ways to treat wounds if they get complicated, but it's been around for many years and it isn't that new. Something that is also not very new, because it has like 50 and 30 years, these procedures are 50 and 30 years old. The TME, total mesorectal excision, and CME, complete mesocolic excision, are approaches to excising colon and rectum with adjacent lymphatic tissue, which improves survival, but it's not a new horizon. We know it. It's been around for 20 years at least, or TME longer. This is something not everybody does, unfortunately. It has to be changed. Smaller hospitals, smaller centers still sometimes don't know it, this operation, but they should. Unfortunately, implementation of new things in surgery is much slower than in oncology. For example, oncologists have a new paper and they introduce it next month into their treatment, and surgeons have a new, quite well proven techniques such as CME, and it's been 20 years since the publication of the results, and still not everybody does it. And it's an issue with surgeons, I guess. We have obviously laparoscopy. We know that laparoscopy is very beneficial for the patients in many cases and many types of surgery, although for colon cancer and rectal cancer, it still has not been proven. We still are cautious to draw conclusions in regards whether laparoscopy is a safe bet for cancer patients in colorectal cancer. In colon, we have a small advantage of laparoscopy with similar oncological results and a bit improved results in terms of length of hospital stay and pain. But in rectum, we don't see it yet. It is possible that it will change over the following years, because at the moment, all of the studies that have been performed and are being performed are kind of done on the learning curve of the surgeons. So maybe when the new surgeons will come, new generations of surgeons will come from my generation, I guess, who have been born to laparoscopy. I've never known any other world than the world with laparoscopy in it. Maybe it will change. The quality of laparoscopical resections will improve, and we will have evidence that it's beneficial for the patients. But at the moment, it's still a question that is being researched and it has not been proven. We have a lot of techniques that improve our visualization and help us to make decisions intraoperatively. We have 3D visualization, which is a nice gadget, but it isn't very widely used. We have indocyanine green, which can be used to improve visualization of blood supply and lymphatic tissue. And we have endoscopical approach. In endoscopical approach, we also have enhanced visualization modalities such as virtual chromatoscopy, and especially of note in endoscopy, we can do increasing amount of procedures. We have also this procedures which is called transanal total mesorectal excision, which has been very everybody was very interested in it, but recently papers were published that it isn't very beneficial for the patients. So now it's has been stopped. We stopped doing it. We have this technique which is called transanal endoscopic microsurgery, in which we place instruments through the anus, through this huge tubus, and we excise locally lesions that are in the rectum. But even more interestingly, we can do kind of the same with technique that is called ESD, endoscopic submucosal dissection, which is performed endoscopically, and lesions that are in situ can be excised in this manner. And the bottom line of this lecture probably is that beyond the fact that surgeons have to think in modern ways and look for new things to do and to improve their practices, probably colonoscopy at the moment is the laparoscopy, is what laparoscopy was 20 or 30 years ago. It's the future of treatment. I suppose we can do more and more types of procedures with use of endoscope. It's completely non-invasive. We don't do any laparotomy or laparoscopy to perform endoscopic resections, and probably it will, the role of endoscopy will be bigger and bigger. We even have this procedure which is called FTRD, full thickness resection device, in which we can resect the full thickness of colon with use of colonoscope. So we could even excise T1 lesions in this way. We can also do hybrid operations, ESD plus laparoscopy, to navigate the endoscope if it's necessary. Obviously, we have robotics, but at the moment, for colorectal cancer, robotics are still not a proven evidence-based choice for treatment. Obviously, it's very medial. Everybody wants to have a robot, to have a Da Vinci or another robot. It's very interesting, but we still don't have evidence that it's actually beneficial for the patient and also cost-effective, because it's very, very expensive still. And finally, we have some other developments, such as neuromonitoring for the pelvic nerves to navigate us through the anatomy, and monitor for injury to the nerves to preserve urogenital function of the patient. So again, the bottom line is that we have to remember that all of us are a team, surgeon with medical and radiation oncologist with case manager and a stoma nurse. We have to work together and improve the treatment of our patients in a multidisciplinary manner. Okay, thank you.
Thank you very much, Doctor, for your excellent lecture. And we've got one question for you.
Yes. Well, you can't really overestimate the value of early diagnosis in oncology. Therefore, we would like to ask you a question concerning the screening methods. Well, epigenetics had its, well, so to say, great blow in the last 10 or maybe 20 years. And therefore, do you think that the use of novel biomarkers like miRNA molecules could replace the standard screening methods that we use nowadays? And actually, should we look for better screening methods than those that we have right now? Are they sufficient? And let's not really get into the financial side of this topic. Let's just stick to strictly medical side, so to say.
We not only should, we are, right, looking at it. There are, I'm not a molecular biologist, so not an expert on that topic, although we, at our, I'm even doing a research on ctDNA ctDNA assessment with use of digital droplet PCR in colorectal patients. The issue with biomarker is that it isn't homogeneous, right? The colorectal cancer isn't homogeneous. You have colon cancer, you have rectal cancer. Some of them have one kind of set of mutations, one kind of set of epigenetic changes, another have another one. As an example, although it's not epigenetics, rather genetics, but the research I'm doing is based on KRAS positive, KRAS mutated colorectal cancers, and only 40% of them are mutated, of the colorectal cancers. So obviously we should be looking for biomarkers. It is always of interest. It is always good to have a biomarker that you can assess easily from blood, like kind of by the way to some other examination. And it's obviously the future. Although in the specific case of colorectal cancer, we still have an interesting kind of opportunity to examine stools for something. So I'm kind of wondering whether we should be rather looking for a blood biomarker, or maybe we should be looking for some novel biomarkers in this tool. But there is also a third consideration that maybe still colonoscopy is the best solution, because, you know, the probability that you will find a biomarker that will allow you to accurately diagnose adenomas or even advanced adenomas isn't that high, because this is not a malignant tumor. It is not infiltrating vessels. It is not infiltrating submucosa even oftenly, always if it's not infiltrating submucosa. So I don't know how probable it is that we will find something that will allow us to diagnose them. And if we do colonoscopy and we see them with our eyes and we excise them, we are not only diagnosing patients and we are not only screening for colorectal cancer, we are preventing colorectal cancer. We know that 1% of screening population in Poland, between 50 and 65 years old, will have colorectal cancer in the screening setting. But in 5% of them, you will have advanced adenomas, and probably 1/4 of them or something like that will mutate and will form colorectal cancer eventually. So even 10% of people getting colonoscopy will have the benefit, the exact benefit in that, which will either be a resection of the adenoma or diagnosis of the cancer. So it's a hard question, and obviously we will see. It's sure that we should be looking for both genetic, epigenetic, proteomic, lipidomic markers, and we are doing it. Even we at our department are cooperating in such experiments as you're asking. But I'm wondering whether it will be ever possible to diagnose in this manner precancerous lesions, which are good to be diagnosed, because after excising them, we can safely prevent cancer with minimal complications and with almost no chance of recurrence or minimal chance of recurrence. Although, on a last note, in Poland, we had colonoscopy screening program up to this year. And since next year, it changes into FIT screening program. And if FIT tests are positive, the patient will be referred for colonoscopy. So we are kind of falling back from the colonoscopy, and with FIT we will not be able to diagnose colorectal adenomas as well, probably, because they would have to bleed, and they rarely bleed, as surely much less often than cancers. So maybe there, well, while biomarkers will not be will not compete with colonoscopy, I guess they will surely compete with FIT. So that's my answer.
Thank you very much for this broad and very interesting answer, and of course for also very broad and interesting, equally interesting lecture. Thank you very much.
Yes, and we would like to thank all our speakers for their amazing lectures. And now we move on to the Q&A panel concerning working abroad as a doctor. We would like to welcome Dr. Anna Gomulska, and unfortunately, Dr. Julia Tryzna won't join us today. We remind you that during the lecture, during our Q&A panel, you can also ask your questions in the comment section on YouTube. So I would like to ask you, Dr. Anna, for turning on your camera. And hello, nice to see you. So first of all, I would like to ask you to tell us something about working, where you work, and what kind of work you do, and how long do you live and work abroad?
Hi. So now I work in Germany as assistant Ärztin, so like a resident. And this position I have for a month, but I'm actually here for more than like almost 4 months. For 3 months, I was working as hospitantin, so it's something like practicant. I was waiting for my doctor documents from Germany. That's why I couldn't officially start my work.
Mm-hmm. Okay, and what, so to say, documents were needed to start working in Germany? What you had to do to work in Germany?
I, first of all, graduated. So I graduated in Poland, and then had to also finish the Polish internship. It's 13 months of internship in Poland. It doesn't exist in Germany, but because in Poland we need our doctor's ID, like we get it like after this internship. They also require that in Germany now from us. So I finished that and also passed the medical exam in Poland. And then I I needed also a German certificate, language certificate. I passed it in Goethe Institute. I passed C1 level, but I know that most of the lands requires only B2 level. Mm-hmm. And with these documents and a few more, I could apply for approbation in Germany. And when you apply, they give you the date for your FSP, so Fachsprachprüfung, which everyone has to pass, like every immigrating doctor has to pass. And this exam is a language exam, but medical language. And everyone has to pass it in Germany.
Was it really hard to pass this Fachsprachprüfung?
Actually, I didn't pass it yet. So okay. My situation is right now like this, that my FSP is going to be in February, but because of the situation with COVID, they really need doctors right now. So they agreed to give me something which is called Berufserlaubnis. Normally, the doctors from EU countries don't need this because we just need to show our diploma and then pass the Fachsprachprüfung, and then we get approbation. But Berufserlaubnis is usually for doctors out of EU countries, and because after Fachsprachprüfung they also have to pass Kenntnisprüfung, which is a medical exam, and in this time between these two exams, they are using this Berufserlaubnis, which allow them to work and earn money as doctors, but they always have to have someone looking for them because they are not, they can't, for example, start the residency. They are getting money like residents, but it doesn't count to the time of residency. Okay. And I have this paper right now. And I'm using it until I pass my Fachsprachprüfung.
And actually, in which Bundesland will you pass your FSP?
Niedersachsen.
Oh, schön.
Hanover, yeah.
Oh.
Okay, and how long before you decided that you want to live and work in Germany did you study actually German language?
It's really hard to answer this question because my history with German started really early. I think I started in elementary school, like first like private lesson, then I had this language in school in middle school, and like in middle school I actually started like having like a better like my language was pretty good because like we had a lot of lessons, and I also took part in exchanges with German students. But then in high school and the beginning of college, like I had a long break with German and decided to start learning German again around third year of my med school. And then I decided to go for Erasmus. That was 5th year of my college, and before Erasmus, I actually decided to like prepare more and started learning German more frequently.
Okay. Okay. Well, so maybe now I would like to ask you, what did you fear the most at the beginning of work in Germany?
Fear.
Yes.
Language barrier, I think. Like I said, like my German wasn't that great when I went for Erasmus, and I had a lot of problems and a lot of stress usually with communication there. Then after coming back to Poland, I was keep studying German, but they were also like the end of my med school, so I had a lot of exams and the medical exam to pass. So there was always something else happening. So like I still had like a lot of fear that I won't be able to communicate, and I don't know, like it didn't happen just one day. It was like step by step, just like every time I had to like call somewhere or organize something, it was like going easier with the language, I guess. But it doesn't mean that it's perfect right now. Like I still don't understand stuff. Sometimes I still have to ask questions. I still use a translator, right?
Yeah, of course. As you said, it's a process, so it takes time.
Yeah, but fortunately you are in Niedersachsen. Actually, I also study in Hanover, and it's true that Niedersachsisch people use very, very clean, so to say, German. They don't use...
And not where I am.
Really?
So I work in Aurich, which is a small town, but this part of Niedersachsen is, it's really close to Netherlands, and the language they use here is called Plattdeutsch.
Yeah.
And so it's something between Dutch and German. Exactly. And if people from here, like they grew up here, they use this, they have a bit different accent, they use a bit different phrases, and sometimes it's hard to understand. But yeah, like we communicate in Hochdeutsch at work, and we do documentation in Hochdeutsch.
Of course.
I was in Switzerland for a month, so like I know how it is when you don't understand at all, even if it is German, but like not really. So yeah, yes. It's hard with the dialects.
That's true. Yeah, okay. And have you already found any differences in lifestyle in Germany?
In Poland. So
I think actually the difference is not so big because first of all, we're like German is our neighbors, and our culture, I think it's similar. Even our food is similar. And like I said, I've been in Germany multiple times, and I know people from here. So that wasn't a cultural shock for me. I think it's a bigger difference for someone who's coming from out of EU countries. But yeah, for me, it wasn't a shock. There are differences, and there are stuff which I like better here, but also stuff which I like less. Yeah. Like the internet connection here. I don't know what's about, but like it's always more expensive and it's not that good usually. Also, like organizing different stuff online, it's not always possible in Germany. Like a lot of companies still want you to be there in person to register, for example, or they're really bad with answering emails. I had this problem already during Erasmus. Like I had to call. Like it's also bad when you apply for a job, like you send multiple emails, but you always have to call. Like you shouldn't wait for the answer just by email because like they probably didn't notice this email. So you always have to call.
Yeah, that's true.
Germans don't really like using credit cards. They always prefer cash.
That's also true. Like many times they don't have a possibility at all, or if they do, only one type of cards work.
Yeah.
So yeah.
Yeah, that's kind of a
So
culture.
you always have to have cash with you, but it's slowly changing, I think. Thanks to COVID, actually, because like they had to change a bit because of quarantines and the lockdown.
Okay, I've got actually another question also. Now you are working as a doctor, of course, but now, I mean, taking into consideration that you are a doctor from abroad, from Poland, do you have to do everything all by your own, or you can, get some help from your colleagues? Are they helpful for you?
I think it's a really important question because I think it's a really important for someone who just started the work. Like this is my first work in I'm working gynecology. I only work in Poland as intern. I did this internship, except that I didn't work as a doctor. So for me, it was really important when I was looking for a job if the people there will help me with this, will understand that it's a beginning for me. And of course, like I need some help at the beginning, not only because of the language, but just in general, like with medical stuff. And I'm lucky and I found a place like this where people are really helpful. Actually, all of the assistants, so all of the residents are foreigners, but they already work here longer, like about 3 years or longer. So they have experience not only in medicine, but also in working in Germany. And they understand my problems sometimes with language. They understand what I'm struggling with during my first job. And yeah, I think it's a good team. Like they not only answer all of my questions, but also sometimes offer they help when they just see that I'm struggling with something. So I think for people who are looking for a job, they should try to observe how the team is working together, especially residents, because as a new person, as a resident, you probably will learn more from other residents than from specialists. Maybe it's different in bigger hospitals, like clinical hospitals, but in smaller hospitals, the specialists usually they have their own patients and they don't sit there with you. They don't are there always with you. There are like you can call them when you need help, but they are not there to show you everything step by step. So you will learn from other colleagues, so from other residents. So when you are applying for a job, when you're interviewing, usually in Germany you have possibility to do hospitation, so like 1 day or a few days of just being there, working, like following other doctors, having possibility to talk with them. And then you can observe how they work together, if they help each other. And you can also, what is important, you can try to ask if like how long they work there and if they are planning to stay there. Because if people are leaving and the workers are changing all of that, that's not a good symptom.
Yeah, that's
actually
true.
Very useful hint.
Yes.
Yeah, like I said, I did practice in Switzerland where I experienced not a great atmosphere, and I didn't have possibility to learn from residents there, and I actually didn't do too much there, and I was disappointed. And then when I was applying for a job in Germany, I actually pay attention to like how people are behaving there, and if I could be able to learn something from them.
But all in all, what you said about the clinical hospitals, I think that in Germany, it's very nice that there are those doctors who are called Oberarzt. Yeah,
that's a specialist. Yeah, I mean, Facharzt is a specialist, Oberarzt is a position, but
they like half step between the head of the department and the regular, so to say, doctor. And it's actually good because from our experience on the internships and so on, we had contact with many Oberärzte who actually helped a lot their team. The younger doctors came to them and they could consult the harder, more difficult cases, right? So that's actually quite a nice thing that they have.
Yeah, and like I said, like when I want to, I can always call them or just go where they are and try to ask them questions. But like, you have to have, it's mostly about medical knowledge. Like I said, I don't have experience. They have a lot of experience. But with the problems like organization problems or like language problems, I don't think Oberarzt will, he has other stuff to do, right? Like, so you have to ask your colleagues, and so that's, it's good if they not only have time, because like sometimes they are also busy, but they need to want to help you.
Yes, naturally,
yeah. Yes, and actually I've got one last question, because we should start lunch break, because you mentioned that you also were also an Erasmus student. Would you recommend taking part in Erasmus plus program mobility to our participants?
Yeah, of course. I'm recommending all of the possibilities to go abroad, experience working or just living with people with other cultures and other experiences. If it's Erasmus or other programs, I also took part in like EFMSA exchanges, but also like organized practice myself. So Erasmus gives this possibility that you don't have to like, you can save some money because of Erasmus. So it's really important for students, especially medical students, which usually don't have time to work extra. So yes, I recommend it. And actually, I think I made my final decision that I want to work abroad when I was doing Erasmus. Yeah.
Right. Okay, so thank you very much, Anna, once again, that you decided to share your experiences with us today. And now
it was a very important insight from your side, so thank you very much. And now we would like to move on to our lunch break, which will last for 1 hour, I guess. Well,
yes, it finishes at 14:15.
Yes, exactly.
So see you soon.
Welcome back after the break. In a moment, we will begin with an interactive quiz. In order to participate in a quiz, you need to take your phone and enter the website kahoot.it, and then click play. The window will appear where you can insert the code, which will be shared with you in this transmission in a minute. After you insert the code, the game will ask you to write your nickname, which will be your representation throughout the game. After the participants enter the game, the quiz will be launched.
There are 15 questions, either as a multiple choice question or as a true-false questions. Your telephones will show you the buttons in the colors matching the answers at our screen. You have to answer not only correct, but also fast, because both measures are equally important in order to win. After each question, the current table of scores will be displayed. Don't worry if you do not end up in the top. The ranking usually changes itself multiple times throughout the game.
The winners of 3 first places will be given a prize. We have to ask them to contact us by email, sending the screenshot which will confirm that you are the winner. I hope that the rules are clear. So now we'll move on to the website, which shows you the code. Oh, I see that we have already some of participants.
Okay, actually we've got already
8
8 participants, but we are going to wait for a while.
Yes.
I think maybe 3-4 minutes.
Yeah, I think we'll start at 14:20.
Yes, so now just log in, use this PIN code, and we'll start.
Okay, as I said, it's already even after 14:20, so we can start. We have 12 participants.
And yes, I want to say only that remember that you need to answer not only correct, but also fast.
So let's begin.
Okay, so it's of course IMEC 2021 day 2nd. And the first question is, choose the answer containing only positive symptoms of schizophrenia. And you've got 1 minute. Okay, we've got 9 answers. So only 3 left. Okay, so the correct answer was answer yellow, and 5 of our participants answered correctly. So let's take a look at the table of scores. Okay, so ET is number 1, but now, and A9 is right behind him or her. So, second question, schizophrenia. Which answer is correct about schizophrenia?
Which of the following is true?
Okay, 10 seconds left.
We'll still wait for 5 more. 4.
3, 2, 1. Okay.
Okay.
Wow, it's quite a good score, I think.
Yeah, most of you got it right, actually.
Okay, it is still on the first place, but now V, right, is on the second place. Now, true or false? Adrenal gland produced aldosterone and cortisol. Is it true or false?
This question might be easier for medical students, actually.
Yes, but we need also, sorry, I just missed the word. Okay, I think it was quite easy. Yes, that was the word I was looking for.
V is on the strike.
Okay, question number 4. Symptoms of Turner syndrome include. What I wanted to say was that we need also easy questions, right?
Yes, that's true. Great.
Okay, I think that wasn't very difficult.
Yeah, I see that you are very well aware of what Turner syndrome is.
And let's take a look. Okay.
And, well, the play is getting very interesting, as 4 players have reached answer straight of 3. That's very good.
Okay, so now question number 5. Which country was the first one to register arthroplasty?
That might be quite difficult, actually.
Yes. Okay, you've got only 5 seconds left.
Let's see. And some of you got it right.
Yes, Sweden was the first country
to register arthroplasty. But as we can see, no, it's only AK who has straight with 4 correct answers. Okay. But still, the scores are very even.
Now, true or false? Turner syndrome is caused by the chromosome X monosomy. Is it true or false? We are waiting for 2 answers. Okay.
And once again, you proved to be very, very well informed in terms of Turner syndrome. Great.
And yes, AK is still on the top and has a streak with 5 correct answers in a row. So congratulations. True or false again? CD4 T-cell autoaggression can cause a metabolic liver disease. Is it true or maybe false? Okay, only 2 answers left. And 5 seconds, okay.
I thought that it might go this way because it's actually quite a tricky question. It causes a liver disease, but it definitely is not a metabolic one. It is strictly steatohepatitis.
Yes, it was also tricky because it was not CD4, but CD8 T-cell.
That also, yeah.
And now, yeah, so
the tables have turned again, so to say.
Okay, question number 8. When organizing the internship with Erasmus Plus program, the minimal duration of the mobility is? So 1 question regarding Erasmus program.
I think that the people who had experiences with Erasmus Plus program might find this question quite easy.
Or listen to our discussion panel.
Yeah, that's true.
Yeah, so for 4 of our participants,
got it right.
Yeah, got it right. Okay, it is still on the top. And question number 9, true or false? Patients with colorectal cancer are at higher risk of progressive sarcopenia. True or false? And great, yes, true is the correct answer.
Well. Yeah, and what do we see?
Okay, so nothing really changed. 10th question, which of the following is not included in fundamental aspects for ACE of schizophrenia? I think it could be quite difficult.
Yeah.
It was the very first lecture, actually. Today, of course.
Yeah.
Okay, so 5 seconds left. And wow, great.
I would have problems with this question, to be honest.
But not our participants,
no.
As we can see. Okay, it is still on the top. And
yeah, and all are chasing ET still.
And we've got still 5 questions. What was the most difficult for our today's guest, Maria Rutovich, during her internship in France? So we'll see who was listening to our discussion panel with Erasmus students.
This might be quite a game changer.
Oh. Wow, you listened very carefully. It is still on the top, yeah, and all are on the 2nd and 3rd place. Question number 12, true or false? Students receive money always before the start of the mobility. Great, yeah, that's false. Unfortunately,
yeah,
that's sometimes problematic. Let's see. Again, true or false, surgery is the same as operation.
Obviously, it's not a linguistic question. Yeah, it refers to one of our lectures. Yes, but you got it right.
Let's see. Okay, now all is on the 2nd place.
Yeah.
Which cells were involved in autoaggression and development of steatohepatitis? Okay. Yeah, great.
It was quite an easy question, actually.
And
wow! That I am actually surprised with.
Yes, so yeah, it's now on the top.
Yeah.
And the very last question. IMEC 21-22 lectures came from 6 countries. Which of the following is one of them? Great.
Yeah.
Yes, we had a couple of lecturers from Ljubljana, Slovenia.
Yeah.
Great.
We had participants from Albania, and Sweden was included just to cause a confusion. So, yeah. Great.
And let's see. Third place.
All.
Or OL. Second place, ET. And the winner is... Yeah, so congratulations.
To all of you.
Yes, remember to send the screenshot of your Kahoot game to confirm that you are playing under this nickname to our email address. It's imec@sum.edu.pl.
Yeah, you can easily find it on our website.
Yes, so that would be easier. So thank you very much for participation in our interactive quiz. And well, now it's time for closing ceremony.
Yes. Congratulations to our winners once again. And we would like to thank very deeply and sincerely to our lecturers who did a great job, who presented us very, very interesting topics from the numerous branches of medicine.
Yes, we would like to also thank all guests we invited and who participated in our conference. I mean, students who took part in Erasmus program mobility, also doctors working abroad. And well, we want to also thank all our participants because without you, our conference wouldn't exist.
Yes, we would also like to give special thanks to Professor Szczepański, who is Director of Medical University of Silesia, for giving, obviously, a wonderful lecture, and also for giving a very special honorary
to our conference, yes, and as a special support, so to say.
Yes.
And of course, we would like to thank very deeply our Professor Justyna Paprocka.
Yes, who helped us enormously to organize this conference and supported us through the whole process.
Yes, and last but not least,
special thanks to our IT support, who, yes, now they are waving their hands. We are very, very grateful for the support because the whole conference was really, really well organized due to them.
Yes, so once again, thank you all. And well, I hope that maybe we'll see during the second edition of International Medical Erasmus Conference next year.
Yes.
So hopefully, see you soon.